Okay, it is 10:11 and our number isn't going up from 140, so I guess we will start today. So you guys are winding down. Congratulations on getting to the end of term one. I know it's really exciting. Before we get into the pulmonary stuff, I just want to touch on, because you guys have your OSEX and your lab exam both on Thursday. Am I correct?
Correct.
Yep.
Okay, cool. So OSEX and lab exam, Brady can give you his 2 cents too. I wouldn't stress about those exams. They're not worth very much. And because we're online, they know you're online. And so it's not going to be as intensive as it would be if you were on the island, if it's similar to what we had. So I would use the day before. I mean, you don't need any more than the day before, I don't think. For the OSEX, print off all of your, or I like to print off, but and go through the nitty gritty details, make sure you know all that. They're not going to test concepts, they're going to test very nitty gritty details. The lab exam, go through the quizzes that they give you. The lab exam will be very similar in style to those quizzes. Very first order, very second order. I screenshot all of the answers when you go back and you look at your how you did. I screenshot all that. I went through. If there was second order stuff, I made sure to go back into my lecture notes and fill in all the second order stuff so I knew what was going on. So don't stress about that too much. I would take the day before, but definitely focus your efforts on CPR too. So
I second that. Definitely the rubrics for the OSEX. It wasn't as detailed as I thought it was going to be. So I feel like, me and all my friends, we all did well. I think that class average was pretty good. So as long as you could kind of work through the process of what to do and in certain situations, it's pretty straightforward. As for the lab exam, I second that as well. By all means, do the lab quizzes, make sure you understand the images, take the lab quizzes and go and label things that aren't labeled, like assuming they could take the same picture and label something separately. Also, in regards to the scans, like X-ray, CTs and stuff, it may be helpful to go through the labs and just look at those images, or maybe go through those few lectures that you had regarding the imaging lectures, just to make sure you can point out the stuff that's on the CTs and stuff like that. But I did note that a lot of the questions in the lab exam were second order questions, but primarily the images being the same, most of the questions on the actual lab test were first order. So take that as you will.
So like, was it like just identifying stuff that they have an arrow on and stuff like that, or like what innervates this organ or this muscle, stuff like that?
Yeah, both, but
yeah.
primarily it was just first order, like what is this, but they could ask you innervation as well.
The images that they were using, are they coming from the Gray's clinical dissector?
They could technically, but correct me if I'm wrong, Lindsey, I think their images were actually their images, like from
Yeah.
SGU. So
I don't think I remember any images that were straight out of the dissector.
Yeah. I would primarily do those lab quizzes. Clinical correlates on the lab practical. Not exactly. No, it wasn't. It's not like you're thinking for the actual exam, like the CPR2 exam, where you have to like read into things. It was very, very straightforward.
Very straightforward.
Yeah.
It was more straightforward than I thought it was going to be.
Right, exactly. Watch the videos again. If the videos help you, then, I mean, you could, but I would look at the pictures. Just look at the pictures.
Yeah, I agree.
Look at the pictures.
Just look at, well, and also look at the pictures because they'll reuse those pictures. And so the image will be the same or very, very similar to what they're going to put on the exam. And so you know exactly what you're looking for. And I agree with Brady. Don't just focus on what the quiz asks you to identify everything in the image, because there were 2 or 3 on ours that it was the image straight from the quiz, but the arrow was in a different place. So make sure you can identify the whole image. And when they ask the second order stuff, make sure you can answer the second order stuff for everything in the image.
Yeah, I don't know if you'd say it's easy points, but I think the class average was pretty good. So I think the idea is to bring your grade up a little bit. They gave us our scores back pretty quickly, 2 or 3 days, yeah, for each. Yeah, but y'all have y'all's back to back. They may just give all of y'all's, just rip off the Band-Aid and give all 3 of your scores at once. So, hey.
Quick question. What about I don't know what we were talking, physical examination?
Mm-hmm.
The OSEX?
Yeah, that.
Yeah.
Mhm.
That's just off of the rubrics. So the small group, the manual and the small groups slides they give you, that's what it's going to be based off of. And so go through there, and if it's anything like ours, it's like step 1, step 2, step 3, step 4, and it literally takes you through how you would conduct yourself in a patient encounter with that specific exam. That's what they're going to test you on. And of course, the information surrounding that is fair game as well, that it kind of supplements the stuff, though it doesn't really deviate. But it's all the nitty gritty. Like, for example, if there's a spinal level that they're testing, they're going to ask you what the spinal level is. They're going to say, oh, we did this test. What are we testing? So make sure you are paying attention to all of those details in those rubrics, because that's very, very testable.
Thank you.
And just so you know, because in case they do like for y'all like they did us, obviously first thing you do when you walk in the room is you wash your hands first thing. Then you stand at the foot of the bed, whether you do this in real life or not, whatever. For the test, you stand at the foot of the bed, you introduce yourself, then you go to the right side of the bed to
They didn't
examine
ask
the
that
patient.
question, did they?
They may or may not have asked that question, so
Yes.
just stand at the foot of the bed, introduce yourself,
Oh,
go to the right side. So whatever. I don't know if your patient's gonna get mad if you stand on the left, but hey, I don't make the rules. All right.
Thank you so much. That's very helpful.
All right, no worries. All right, should we get started?
Yeah, let's go for it.
Let's do this. All right. Obviously, everything's posted here on the Facebook page. Lindsey has the Dog Lounge DES page as well. I'm sure all of y'all are in both. So we'll put updates there. We'll post the recordings after as well. I put a bunch of extra stuff, additional resources, not only old questions and stuff I thought was helpful, but me personally, like the weekend before, the 2 or 3 days before, I go through all the lectures and I write like shorthand notes, like literally just like maybe 5 pages of just things that like I have to stare at right before the test. I scan those in and posted them for you. So it's my handwriting. I like to think it's neat, but like all the equations and everything, it's there. It's just a couple of pages. It's just like bare bones, like shorthand, just recycle it over in your head. So if you want to look at that, go for it. All right, Lindsey's going to start up with lymphatics.
Was there a question?
No, I just said you're a lifesaver. Thank you for that.
Yeah,
Oh.
no worries. Yeah.
Okay, so again, my stuff is incorporated into Brady's. At the beginning, when we started doing these reviews, it was separate, but I thought it was a lot more efficient if we just incorporated. So, okay, we are starting out with the lymph system. You will have a handful of questions. So the lymph system is broken down into different cells and organs. So this is just an overview of the main stuff that we'll hit on. Yeah, next slide. So when you're looking at the cells, I just put it all on one page, the big things that I pointed out as you should probably be aware of. So T lymphocytes, the biggest thing, they differentiate in the thymus. That's really important because there's a clinical correlate that goes along with that. They're going to recognize antigen. So that's the MHC, which we'll talk about that when we go to the APCs. You have the T helper cells and the cytotoxic lymphocytes. So you do need to know which is which because they can get that specific on the exam. So T helper 1s are intracellular pathogens. T helper 2 are going to be extracellular pathogens. They interact with the B cells, antibody mediated immune. So make sure you do understand that. And then these are T helper talk to CD4, or they have CD4, and they're going to talk to a specific MHC. And then cytotoxic lymphocytes have CD8, and they're going to talk to a specific MHC. So make sure you do know that. We were tested on the difference between those two. So make sure you can make that distinction. Then cytotoxic, cancer, and viral particles, anytime they distinguish if there's a certain cell line or a certain type of infection, it's testable. So you guys had the other immune cells on CPR1, and so you go through, and some of them are for different kinds of infections. So that is important here. I put the CDLs on here. They bolded CD3. I don't remember this being a huge thing, but if they do bold something, I would make a note of it. They did bold CD3 here as proteins associated. T lymphocytes is, of course, is humoral immunity. So on its surface, it has these three things. Number one, an antigen, that's what AG is, antigen binding site, the B cell receptor, and an MHC2. There are two types. These are plasma cells, memory cells. Plasma cells are just the ones that are producing antibodies. So they're the ones that go out. They immediately differentiate. They're the first ones to differentiate in the B cell line. And then memory B cells are the subsequent encounter. So the plasma cells you're going to make, you go in, you recognize something, you're like, okay, we need to protect ourselves against this. Memory B cells are just that. They are the memory line. And so they're going to go is like, oh, hey, you're back. And so that's what the memory B cells are. NK cells, these are innate immunity. The biggest thing is they're going to release granzymes and perforins. This is how they are going to induce apoptosis, since this is kind of a deviation from all of these. This is really important and testable. So they have FC receptors on their surface, and then they lyse cells that have been coated by immunoglobulins or complement. And then the APCs, these are going to process the present antigen on its surface. So they're going to take it in, they're going to break it down, and then they're going to present it with an MHC carrier. So MHC2 is going to interact with CD4, and MHC1 interacts with CD8. The way I remember this is kind of, I don't know, weird, simple, corny. You need, when you're drawing a 4, you need 2 lines to draw the 4. So I think of that as MHC2, whereas an 8, you just need 1 line to draw the 8. I don't know. If you need some kind of corny thing to remember that, that's how I do it. And then I put these on there. So these are macrophage cell lines. They're different for different areas of the body. I would be familiar with those. I mean, Kupffer cells are a big one, but just make sure that you are able to distinguish those. So you can go.
Question, do we have to know all these CDs that are listed for each one?
I put them on there for completion's sake, but I do not remember that being a huge thing. Brady, do you remember?
Sorry, I was chatting in the chat. What was the question?
Do they have to know the CDs, all the different ones?
No, no, I don't remember. I don't remember this being terribly detailed, just because you have a whole course on
okay, so
immunology. Yeah.
So the big ones we're saying are 4, 8, and 16. Yeah, 4 and 8 are huge because
yeah, for sure.
You definitely need to know those, and you need to know. I remember we did have a question on our exam that asking us to relate the CDs back to which MHC, and so you need to know these. Make sure.
I think also, sorry, I just don't trust what we get told in the lectures, because when we were being lectured this, they told us not to worry about any of the CD numbers besides for 4 and 8. And then when we did our IMCQ session, we had to identify that the natural killer cell was CD94. So I just don't trust that they won't ask us something like that.
Question real quick. There was a question in our CPR 1 where it says like, which of the following cells have both MHC and MH1. So I was just
That should be
wondering.
the antigen presenting cells because they're going to have both on their, they can express both. They just talk to different cells. So the MHC2 is going to talk to the T helper cells. The MHC1 is going to talk to the cytotoxic lymphocytes. So you would have both on the surface so that they can talk to multiple different cells. So you can mount two different responses at the same time.
Got it. Thank you.
Sorry, I have one quick question. So when it comes to your T cells, I know that they can go through colonial expansion and become perforins and granzymes, which is also present in your natural killer cells. So when we do get a question in regards to your granzymes and perforins, how will we be able to differentiate between your cytotoxic T cells and your natural killer cells? Sorry.
Natural killer cells is going to be more innate immunity, and they're going to recognize cells that have been coded. So you have immunoglobulins floating around or complement that are going to surround the cell, and the NK cells are going to recognize that. And that's going to be their cue. Whereas like the cytotoxic, I can't say that word for some reason, lymphocytes recognize antigens. They have CD8 on their cell surface, and they're going to recognize antigens on cells infected with these particles. So I would say it would be the difference in how the immune cell recognizes that there's a problem, if that makes sense.
Yeah, it does. Thank you for that.
Okay, answer this question.
Y'all could just put your answers in the chat if you'd like.
Yeah. Okay, yeah, we're getting a lot for D, which is the correct answer choice. So we are talking about a virus. So the cells are going to become infected with viral particles, and those are the cells that are going to be identified by the cytotoxic lymphocytes. Okay, we have a lot for B, which is going to be correct. We have the NK cells. So good job.
Can I ask a quick question about this one?
Mhm.
I wish I could be more specific, but I remember there being a question at some point where the answer to cells that secreted granzymes and perforins was cytotoxic T cells. In what situation would that make this question, the cytotoxic T cells, the correct answer?
So, like I said before, I think it would just be more towards how they're identifying the issue. I'm gonna look that up because I was looking at your slides.
Good. I think the key in the question here is right here. This innate immunity. Remember, even though that's the natural killer cells are from the lymphoid or progenitor cells, along with B cells and T cells, they're quick acting. They're the innate immunity. You get an antigen and infection, the natural killer cells are going to go quickly. So this innate immunity is what's going to key you in on that. If they said adaptive immunity, think adaptation as having to go through a process, right? You have to present this antigen to the T cell. The T cell has to process it and it has to work with it. On the humoral side, the antigen presenting cell has to present it to the B cell, and the B cell has to make differentiate into a plasma cell, and then the plasma cell has to make antibodies. So just remember, when you're talking about that innate immunity, you're talking about that immediate reaction. So natural killer cells, you're thinking about, you know, maybe especially neutrophils, you know, that's going to be that you know, that immediate mediator. So the key here is that we're talking about the innate immunity.
That's awesome. Thank you. Could we also go over like the different buzzwords for each of these also? Would they be specific like that?
Okay, so cytotoxic T cells are going to be what you're presenting to. Okay, so they're going to be those are you know, those are going to be after the antigen presenting cells, such as a macrophage, presents the antigen to the cytotoxic T cell. Then it's committed to memory, a long-term memory. So your body stores it and it recognizes it as a virus. So you have to activate this. So if you see something that says adaptive immunity, you're thinking cytotoxic T cells. If they say something about you know, antibodies being produced or plasma cells being made, you're thinking B cell or humoral immunity. That's that B cell lineage. Macrophages, I think it's important to make sure that in different cell or in different organs, macrophages are called different things.
Mm-hmm.
In the liver, it's a Cooper cell. What else, Lindsey? In the skin, it's, what is it, a Langerhans cell?
Yeah.
Yeah, so know that. But remember, macrophages are going to be APCs, antigen presenting cells.
Mm-hmm.
They're going to take the antigen that they find that's foreign to the body and go bring it somewhere, right? All the while trying to phagocytize or eat the cell. So
Yeah.
keep that in mind. As for the helper cells, I don't know that they'll get into too much detail with these. Like I said before, you actually go into a lot of detail in the immunology. So if you have a solid definition for everything, if you could kind of work through the process of saying, okay, this is the immediate reaction, this is the memory formation reaction, you should be good.
That was lovely. Thank you.
Yep.
Okay, so for this question, let's start just sending it to me and or Brady so that people have the chance to form their own answers in the chat. I think that is a really good idea. So just send your answer choices to myself or Brady privately. You can actually search our names. I know there's a lot of people in the chat, but you can just search our names. Thank you, guys. So we're getting a few answer choices here. That's good. I like it. We're thinking. Okay. We're identifying some good keywords. Okay. So there are two things that can kind of get you to the right answer here. The first is we're talking about a myeloid lineage. So there are two lineages we're talking about when we're talking about these immune cells. So right here we have myeloid lineage, and we also are showing that we have both MHC1 and 2 molecules on the surface, and of course the CD40. But those two things should narrow it down to macrophages. All of the other cells are not going to be of myeloid lineage. There's like a specific lymphocyte lineage. And so those two things would help you answer this question. And remember, we talked about how macrophages have both MHC1 and 2 molecules because they can talk to multiple different cells.
And that's going to be important in the antigen presentation or the APC point. That's where the macrophage is kind of just handed over, right, to the MHC component. And so that'll help you differentiate. But yeah, make sure you know that the MHC1 and 2 is classic for the macrophage.
Isn't only antigen presenting cells have both MHC1 and MHC2?
I don't
any of the
think
other
that's
cells have both.
I don't think that's true. I think that's specific to macrophages, but you'll have to double check me on that.
Okay.
Macrophages are antigen presenting cells.
But are they the only ones that have MHC1 class 1 and 2? I think that was the question. I'm not 100% sure on that.
What I meant is all antigen presenting cells have both. Like regardless what it is, but I think the antigen presenting cells are the only ones that have both, and the rest have like one, I think.
Okay, maybe so. I know all cell lineages have one, and then maybe it's all APCs. I'm not sure if it's all APCs. Okay, yeah. I don't know if it's all APCs have both MHC1 and 2, or if it's just, or if it's specific to the APCs being macrophages. You have to double check on that one.
I think every cell in the body has MHC1, and the antigen presenting cells are the ones that has 2.
Okay.
The MHC1 and MHC2.
Okay, thank you very much.
But isn't a B cell also an antigen presenting cell? And I'm pretty sure it only has 1.
Yeah, that's why I was getting a little confused. You want to run the screens, Lindsay?
For that previous question, it was asking about something coming from the myeloid lineage, and that's the reason why the B cell wasn't the right answer.
Right. Well, yeah, that was my macrophages was the only one coming from the myeloid lineage. Lindsay, it makes me shut it down. I have to like do my system preferences if I do it, so I'll just do it.
Oh, okay.
So the correct answer was indeed macrophage, right?
Yes.
Yes, right. Because remember, the lymphoid lineage is going to have the T cells, which is the cytotoxic and the helper cells, the B cells, and the natural killer cells. Those were all options. And the myeloid, the one that was from myeloid lineage was macrophages. And remember, like neutrophils, basophils, those are all going to come from the myeloid lineage as well.
Yeah. Go up one to the previous slide, Brady, real quick.
Sure.
Okay, I just wanted to make a point here real quick. When we're talking about lymph organs, you need to know how to identify them. It's not going to be straight identification in the questions, but what they'll do, they'll give you a scenario, and then your answer choice, they might put all of the different lymphoid organs on there, and you have to choose which one they're talking about. So make sure, and we'll go over each one of them, make sure that you are able to identify each based off of its characteristics. And again, we're going to go off the characteristics of each. Okay, lymphatic tissue. This is diffuse lymphatic tissue. This is just non-encapsulated, localized accumulation of immune cells, molten gall, so that's associated with it. This is basically just the walls of different organs. So walls of the GI, respiratory system, GU. These are sites where you have very high and very continuous exposure to pathogens. Think about this. The GI system is an open system essentially to the environment. The respiratory system is directly in contact with the environment. The GU system is directly in contact with the environment. And so you need kind of a first line of defense there so that if something aggravates the area, you have something set in place to catch those pathogens, to say, oh, hey, genitourinary, and say, hey, something's trying to get inside, something's trying to hurt us, we need to mount a response, or we can, catch it before it gets anywhere. So that's what this diffuse lymphatic tissue is. It's associated with any part of the body that is kind of open to pathogen, and it's just accumulations of immune cells, non-encapsulated, so it's not one organ. You have diffuse lymphoid nodules right here. This is a nodule. This is a nodule. Sorry, I was getting kind of fancy with all this stuff. But this is what you're going to see. It's more just like small lymphoid nodules. They're not encapsulated. It's not going to be an organ. You don't have a capsule here. Most of your lymph organs are going to have a capsule with some connective tissue. So this is not that. So examples like the Peyer's patches in the ileum, the duodenum has, I forget what it's called, even though we were just tested on it. But and then the malt and the gall, all of these are going to be that diffuse lymphatic tissue.
Lindsay, I don't want to cut you off, but let me just clarify this. So for the lymphatics, MHC1 cells are going to be on all nucleated cells. MHC2s are found specifically on macrophages, dendritic cells, and B cells. Okay.
All of the associated lymphoid tissue is going to kind of fall under this. Everything else is going to be more organ specifics. Okay, so the thymus. The big thing here, you're going to see lobules. So the first three things I put, this is really important. It's very characteristic. There are no afferent lymphatics, continuous capillaries, and it's from the third pouch. I don't know if third pouch is important for you in term 1, but just put it on there because in a couple places it talked about it. So how are you going to know that this is the thymus? So we have a capsule right here. That's connective tissue, and they have the trabeculae that kind of deep dig down here, and the trabeculae, this is what are going to form the lobules right here.
Lindsay, we can't see your mouse.
Oh,
yeah,
sorry.
That's
why I wanted control. Oh, I'll annotate. Hold on.
Yeah, you could do that.
There we go. Okay,
sorry,
cool.
Guys. If I allow her to do it, I have to shut the whole system down, and so sorry.
Okay. So right here, we see the capsule. So that's this outer layer. This is all connective tissue. Here, you're going to see the trabeculae, and they kind of dip down deep, and they're going to form these individual lobules. This is the big thing. This is how you're going to be able to identify this organ, because you are going to have these deep trabeculae and of connective tissue that are going to distinguish the lobules, and then you're going to be able to see almost like individual parts in here, because other organs are going to have the trabeculae, but they're not going to be as long, and you're going to see they don't really separate into these lobules. So these lobules, you're going to see they have a very basophilic cortex and a very eosinophilic medulla. That's how you're going to be able to tell the difference between the thymus and any other organ. So again, no afferent lymphatic. Okay. So in the cortex, what do we have here? Because this is important. We have immature T cells, and you have epithelial reticular cells. Now, the epithelial reticular cells are going to do two things in here. They're going to be supportive cells that are just kind of interspersed between all of the immature T, but they're also going to surround the blood vessels, the vasculature, and form that blood thymus barrier. Why do we need a blood thymus barrier? These are immature T cells. We're sequestering it from the blood. What does the blood have? All of these antigens. We don't want to expose all of these undifferentiated immature T cells at this time. We're just kind of letting them be. But as they mature, they're going to travel to the medulla through the medullary blood vessels, efferent lymphatics. This is where we're going to have the mature T lymphocytes. And this is where your ERCs are going to degenerate. And those Hassel's corpuscles, which are characteristic of this area of the thymus, this is where you are going to, the Hassel's corpuscles are actually the degenerating ERCs, and they're not going to surround the medullary vessels at this time. So that's only in the cortex. But what's testable, you do need to be able to identify this. I would know that this is, the cortex is immature T and the medulla is mature. They could put a star on any part of this organ, and they could ask you to describe it in some way. So even though like the ERC stuff, it's probably not testable in and of itself, they could combine it with other aspects of descriptions of the thymus to narrow down the question. So it could make an answer choice incorrect if they pair this incorrectly. So that's why I want you guys to understand it, not so much because they're going to test you on this concept right here, but because it could help you identify certain areas of the thymus, if that makes sense.
What is the little thing you circle? I kind of missed it.
Right here?
Yeah.
I was just circling kind of whatever on the screen. That might be a Hassel's corpuscle, but I don't want to definitively say that. But if they say something about the Hassel's corpuscles, it's only going to be in reference of what organ is associated with the Hassel's corpuscles, and then you would have to know the thymus. That's all they would do.
Got
It's
it.
just a buzzword. But we can go to the next one now. Okay, the lymph nodes. These are going to filter lymph to identify and fight infection. So you've been tested on lymph, you know, it's really annoying every single time. Oh, you've just had CPR and MSK, but you need to know the lymph nodes. These lymph nodes are their own system in and of itself, where they have vessels running, they're going through the lymph nodes, and when they go through those lymph nodes, they kind of taste, they sample the blood, and they're like, oh, is there anything we need to do something about? So that's what goes here. So I kind of put it in order, condensed it. There were multiple slides that kind of talked about this. So lymph nodes, it's also a kidney bean shaped organ, kind of. So here, if we compare it to the thymus, you don't have that really big, strong cortex with the trabeculae going down deep. That's not what we have here. But you do have these accumulations, these lobules, or not lobules, but that's the outer cortex. So we'll go through. So you're gonna have afferent lymph up here. You're gonna have multiple afferents up here. And they're coming in, and you have the capsule, and in the subcapsular area, this is where you have subcapsular sinuses and trabecular sinuses. So you do still have a trabeculae, and that's how it's gonna get into the cortex. So outer cortex, which is gonna be right here, you see these accumulations. This is your outer cortex. That's just your B lymphocytes. Pericortex is just the inner cortex. That's your T lymphocytes, and that's where you have the high endothelial venules. This is really important, these HEVs. This is how you're getting lymphocytes in the blood into the lymph. So blood lymphocytes going into the lymph. So that's what happens here in these high endothelial venules in the inner cortex or the pericortex. They can intertwine those terms. And then the medulla is more down here, very eosinophilic. This is where you're going to drain into the efferent lymph vessels, so to exit the lymph nodes. So medullary sinuses, that's where they're going to drain to the efferent lymph nodes. So again, identifications, marginal zones we're going to talk about in the spleen. So again, to identify this organ, the difference between this and the thymus, remember the thymus is going to have that really thick cortex and the really thick connective tissue, the trabeculae diving down deep, forming those lobules. Here we have this outer cortex, these accumulations. You're going to see kind of a bunch of accumulations right here, and then it kind of dissipates as it goes down. And in the middle, you're going to have the medullary area. So you can go to the next slide. Okay, the spleen filters blood. The biggest thing you need to understand about the spleen is red pulp versus white pulp. So this right here, even though it's darker, this is your white pulp. This is another area of white pulp. Everything in between is red pulp. So you need to know the difference between these two. Red pulp is just a network of reticular fibers. This is where we're filtering the antigen and the blood vessels. So in this red pulp, we have the sinusoids. You have endothelial cells lining the sinusoids. That's how your red blood vessels are getting in. But if you have abnormal red blood vessels, these are getting trapped because they can't get through that barrier, and then they're degraded by the macrophages. That's the big thing for the red pulp. The white pulp, you're going to be able to identify the central artery. This is really big. If you're trying to identify the spleen, you are going to see multiple white pulp dispersed. In the white pulp, you're going to see this central artery. This is very characteristic. And then around the central artery, this is more just conceptual, you're going to have layers of T cells and a layer of B cells. And then on this outside, this is that marginal zone. On the outside kind of border of the white pulp, that's the marginal zone. And this is trapping circulating antigen, and it's presenting it to the lymphocytes, because remember, our lymphocytes are kind of in this white pulp area. So, and then we have antigens out here that we're getting from the sinusoids. We have our lymphocytes in here. And so this marginal zone is trapping this antigen and it's presenting it to the lymphocytes, and that's where you're getting the immune response. But the big thing, identification, for the spleen, remember, I'm going to keep repeating this because you're going to have a handful of questions where you're going to have to go through, but the thymus has that big thick cortex and the trabeculae that dives down deep to form the lobules. The lymph nodes, if they show you the whole node, which I don't think they might, but if they show you the whole node, it's going to be like a kidney bean shaped one. Around the edges, you're going to see a bunch of accumulations. That's that cortex. And then down deeper, you're going to see the medulla. But the spleen, you're going to have white pulp scattered throughout. And in the white pulp, you're going to have these central arteries. Okay, we can get in the next slide. And then someone have a question?
Yeah, just in the marginal zone, then you would have the antigen presenting cells, right? You have a lot of antigen presenting cells.
Should be. Brady, you want to help me with that?
Yes, there is. That's correct.
Okay, tonsils. I think the biggest thing with tonsils, honestly, is just knowing their characteristics and where they are. So pharyngeal tonsil, that's up here, posterior pharyngeal wall. So the oral part, and you have the nasal part. Oral part is going to be patches of stratified squamous, non-keratinized epithelium. Nasal part is respiratory epithelium. So they might want you to identify with that. The palatine tonsil, again, stratified squamous, non-keratinized epithelium. And then the lingual tonsils, this is kind of a patch of it on the posterior aspect of the tongue. So shallow crypts associated with mucus glands. This is kind of a deviation from the other. So I would say that's important. Look over these. We did have a question on this. I don't actually remember what the question was about. Brady, do you remember what they wanted us to know about the tonsils?
No, but I just mentioned in the chat, to make sure you can identify these histologically, the differences, whether there's crypts and whatnot. Because they could give you a question regarding that.
Okay, we can go on to the next slide. We have some questions after this. Okay, we're all getting the answer. Good. We know it's T lymphocytes. Another way I could have asked this question is identify the organ that is hypoplastic in this patient. And I could have put all of those slides up there and you would have to identify which is the thymus. So awesome. I wrote this question. Huh?
I was just going to say, what does this kid have?
George.
George.
Yeah, the George syndrome. Exactly. Catch-22. That's how you remember that. Right?
I wrote this question before I knew that you guys had an entire slide on this in your PowerPoint. So I was kind of proud of myself, but they loved a George. So. I'll read this because I put a lot of stuff in here. 30-year-old female presents the ED via EMS from the site of a motor vehicle collision in which she was restrained. This means she had a seatbelt on, traveling 70 miles an hour in the interstate. She's complaining of pain to her left upper quadrant, left chest wall, and left upper extremity. VS is vital signs. Okay. Yeah, we're all awesome. So the answer is B. This is the spleen. How do we know it's a spleen? Because we have multiple white pulp, and then you see the central arteries associated with the white pulp. What is A? What are we looking at here? I know I zoomed in close, but I wanted. Yeah, these are Peyer's patches. So what does Peyer's patches fall under? What kind of tissue?
The unencapsulated one?
They're unencapsulated. They're the diffuse.
Diffuse,
Yeah,
okay.
the galt.
Yeah.
Yeah, the galt. What's C? This one might be a little more difficult. I couldn't find a really good picture on this. C is actually, it's a lymph node. I know that's a really crappy picture. I apologize, but I was trying to, I didn't want to show you the whole organ. I wanted to make a point and like zoom in and try to do it right there. And then D, hopefully everyone gets this one.
The thymus.
Yeah, the thymus, the thick cortex with the thick trabeculae with the lobules, and then it's cortex and medulla. So awesome. So make sure you know all of those. That's going to be very high yield. You're going to have a couple of questions where you are probably going to have to identify it like in this manner. So, okay, we can move on.
Hey, Lindsay, could you please explain what it means by unencapsulated, non-encapsulated versus encapsulated?
It's basically the difference between, hold on.
It simply just means there's a capsule around it.
Yeah.
There's a capsule containing it. It's just a different way of classifying different lymphatic organs. Some, you'll learn later that some specific bacteria and whatnot are specific to the encapsulated organs being destroyed and whatnot. But just for right now, I think all you need to know is to differentiate which one has a capsule and which one doesn't. That's all. Hey, Kishore, what am I doing here? Go to do a right click.
Right click and see if it pulls it up to
it doesn't let me right click. It goes to
the next slide. Okay.
Yeah.
You're using Keynote?
No, it's PowerPoint.
Got it. Okay.
You can see maybe if I do that.
I'll figure it out before our next
Okay.
one.
No worries. All right, cool. So we'll try to get the laser pointer for you guys next time. Until then, you can get to the flash my pointer. All right, so let's try to get into the pulmonary stuff. So we'll start with some anatomy and some basic stuff here. So inspiration, as you know, when you take a deep breath in, use your intercostals, external, internal, and primarily your diaphragm, right? You want to make that negative pressure gradient. So by contracting your diaphragm, you get a negative pressure, and that helps you bring air in. If you're breathing hard, if you're after working out or whatnot, you can use the muscles in your neck. That helps you take a deep breath in. As for expiration, conveniently, it's kind of a recoil effect. So after you take a deep breath in, there's no muscles that you need to use when you're quiet breathing. Just to, you're making a positive pressure in the thorax, so you can breathe out. Now, if you are breathing heavily, you can use part of your internal intercostals and your abdominal muscles to help to breathe out. So they could ask you a very straightforward question. If you're breathing heavily, what helps you breathe in and breathe out or whatnot. So this is a little bit more straightforward, which muscles you're going to use. Remember, primarily you're going to use the diaphragm. Now, this is from CPR1. If you remember, there was this pump handle movement. We're going to bring this back. That's going to be that anterior posterior expansion of the thoracic cage. So again, the whole point is you're making a negative pressure. Negative pressure means you can bring air in. You also have this lateral or this bucket handle movement that you have. And again, same idea is that you're opening up the rib cage, but primarily you're going to use your diaphragm, right? It's going to contract downward, and that's going to allow you to bring the air in. Okay, so now the viscera here, you're going to have the visceral pleura and the parietal pleura. Remember that the visceral pleura doesn't have any pain fibers, any sensation. So a lot of times when you get a respiratory infection, by the time you feel it, it's pretty bad, right? You may have a cough or whatever, you get pneumonia, but it's not really pain you're feeling. You just get congested or a lot of mucus buildup. So if it's bad enough, or you get pleuritis or something in between the pleura and the lungs, then you may be able to feel it because this parietal pleura has somatic innervation. So remember, somatic innervation is more of like, can you touch it with one finger, right? You can pinpoint it. And so you could like that, versus visceral pain is more of like a diffuse pain. You like, my whole abdomen hurts. So this parietal pleura over here is going to have somatic fibers. So if you get a severe infection or some sort of pleural infection, you may be able to feel it, particularly when you take a deep breath in and the pleuras are rubbing against each other. You're going to feel it. So specifically, when we talk about that, around the ribs, costal meaning ribs, you're going to have these intercostal nerves, but down by the diaphragm, it's going to be innervated. The parietal pleura is going to be innervated by the phrenic nerve. Now, remember, the phrenic nerve innervates the diaphragm. Remember, C3, 4, and 5 keeps the diaphragm alive. That's all the phrenic nerve. We talked about this as well in CPR1. There's this nerve bundle here, the VAN, and it goes in that order from superior to inferior vein artery nerve. Hold on. Make sure this is charging. I don't want my computer to die. There we go. Okay. Sorry, hold on 1 second. I think it's good. Yeah, so the neurovascular bundle is, okay. The neurovascular bundle is going to run right under this. So anatomically, it runs inferior to the superior rib. Okay, so if you're going to do a thoracocentesis, you want to avoid this bundle here. So you want to go superior to the inferior rib. So keep the terminology there straight in your head. I put this in here for completeness sake. As it's been in the past, if they ask you something about the vasculature, it's usually about the anastomoses, right? Because that's some sort of clinical aspect you can get. So the intercostals are going to anastomose posterior and anterior. And then you do have some that anastomose on this next to the sternum, peristernally. So you get this internal thoracic artery, and you get this branch point to the musculophrenic and superior epigastric. The venous drainage, remember the azygous vein is going to drain, it's going to run along the vertebrae on the right side, and you have that hemiazygous as well. So I don't know if that's super high yield, but I just wanted to include it for completeness sake. And along with the lymphatic drainage, that's going to go primarily to the thoracic duct and back into the venous system. Okay, so I will do a question first.
Was there supposed to be an image with this question?
No. Oh, yes, there is. Damn it. I'm sorry, guys. Can you get it off of just the symptoms? I don't know. Try your best. What do you think I'm talking about?
No, it's fine. I was just asking, but I think the sentence.
No, there was supposed to be an image, and I had it up last night when I was writing this question. I was like, oh, that's such a good image, but I didn't put it in. I'm so sorry, guys. Yeah, read my mind. I mean, you're getting it right. So I mean, most of you are getting it right.
Don't leave feedback. We don't want your feedback.
Well, okay, you guys are answering the two questions And the reason why I put the difference between these two on here, so I think this is a success. So a lot of you guys are putting A versus D. It's A, and I phrased the question this way because I wanted you guys to understand that when we're talking about this, what are we talking about, guys? Because I wanted you to read my mind, apparently. TEF, what does that stand for?
Tracheoesophageal fistula.
Yep. Tracheoesophageal fistula. And that's an incomplete division of the foregut. And Brady goes over this too, but I wanted to put something in here after this question, just so you guys can, because I spent a really long time, because embryo is really hard for me. It's very difficult for me to conceptualize it. So I spent a really long time making sure that I understood this concept really, really well. And so you kind of have it on here twice. But because I go to YouTube and I try to understand it as best as I can, but you have the groove right here. So this is the foregut. The foregut becomes the stomach. You'll learn that in term 2. But you have the foregut right here. You get a tracheoesophageal groove right here. And then that's what expands out. And then you have the diverticulum that is going to grow and elongate and actually become the respiratory system. And then this division right here, this is the tracheoesophageal septum. So if you don't have division of the foregut right here, if you don't have this growing down right here, you're not going to have the tracheoesophageal septum. So I wanted to kind of repeat what Brady is about to talk about right now, so you guys can see how I mapped it out in my head.
Right. So as Lindsey was saying, the whole point of the septum is to separate things, right? So if you have this incomplete formation of the septum, you're not going to be able to properly differentiate the esophagus from the trachea. Now, and that's what's going to form the TEF. Now, the one you need to worry about is this first one right here. This is the one they're going to talk about. This is the one that's most characteristic. I wouldn't worry about all the other possibilities. So the point is that the child, remember, it's going to be their first feeding, right? And then you get this blind-ended pouch. So the first feeding, they're going to try to take milk in, and they're going to regurgitate, or they're going to cough up, or they're going to, vomit. And the problem is that, well, that this yellow part is the esophagus, right? It's a blind-ended pouch. That's what they're going to tell you. So here you see the trachea, and the distal end of the esophagus attaches to the trachea. So what is this going to look like clinically? Well, you know that when you look at those x-rays, you see that gas bubble in the stomach. Well, they're going to have a significantly larger gas bubble, right? Because a lot of the air that's coming into the trachea is actually going straight to the stomach. So you're going to have a large air bubble. So if you see that, maybe that's indicative of this. So remember, primarily you get this blind-ended pouch, and you also get this formation from the trachea to the lower part of the esophagus, and you should be good. One more thing, if you remember that Bacterial disease, and it's standard for a mnemonic like vertebral defects, anal atresia, the T in that is for tracheoesophageal fistula. So it's like a compilation embryologically. There's malformations, and this is one of the components of it. But if you understand this, then you should get the question right. As for the stages of development, this one is the most important for you right now, because, and we're going to hit this point hard with this surfactant concept, because it's highly testable. During this canalicular period, around week 20, you start making surfactant, and we're going to get into that. But you need to know right now, week 20, you start making it. About week 26, the fetus is viable. So you're actually making enough surfactant to where the fetus can live. So remember, that's about week 26. All right, let's try this question.
Yeah, we got a lot of answers for C. Yeah, type 2 pneumocytes, so C, yeah.
Yeah, that's right. So you're going to see them bunching up here, and then these type 1 pneumocytes kind of make the barrier, right? So you need both of them, but primarily these type 2 pneumocytes. Remember week 26, that's when we're thinking you have enough surfactant for the baby to survive. Again, you see them here, they kind of bunch up at the junction points, but you also have the type 1 pneumocytes as well. So again, the whole point right now to point out is about week 26. Now, what they can do if it's anticipated that the mom's going to have to have a premature delivery for whatever reason, you can give the mom steroids. We don't need to go into the details on why this works, but you can actually provide maternal glucocorticoids, and that will accelerate the formation of surfactant. But when we talk about respiratory distress syndrome and these premature kids that are born, the primary problem is the fact that they can't make surfactant. So that's kind of the defining characteristic at that week 26 point that's going to make the fetus viable. Now, as for lung development, we talked about in CPR1 that the whole goal of the fetus when it comes to circulation is to shun everything to the left side. The lungs aren't working, they need to develop, so we need to get blood. Mom's going to oxygenate it, get it to the left side. So the whole while the lungs are developing, the fetus is swallowing amniotic fluid. And by doing that, a lot of it gets into the lungs, and this allows the lungs to mature. So there's some concepts here that are important. One being the fact that you have enough volume of amniotic fluid that the baby can swallow to allow the lungs to mature. So oligo means too little or less. Hydramnios is amniotic fluid. So whereas polyhydramnios is too much amniotic fluid, oligohydramnios is too little. So if you have oligohydramnios, you can imagine the child's not able to swallow enough of it, so you can actually get hypoplasia of the lungs, or incomplete development of the lungs. Now, there are some hernias that can form. The one you're primarily going to be worried about is this diaphragmatic hernia. You can get a hiatal hernia, or right in the middle. But the primary one is this diaphragmatic hernia. The buzzword you're going to look for is plural peritoneal membrane. So if you have a defect in the membrane, it's going to make a complete hole, right? So then the abdominal contents are going to come up through the abdomen, as you can see here. I want to point it out on an x-ray. You can see all these little air bubbles. That shouldn't be there, right? That's actually the gut. So you can see the gut here that correlates to these air bubbles here. Now you can also imagine that if you have this, then the baby can't swallow the fluid. He can't expand the lungs during development. So you're going to also get lung hypoplasia with this. So they could ask you that if you get some sort of diaphragmatic hernia of the pleural peritoneal membrane and the lungs aren't able to expand properly, you can actually get lung hypoplasia, right? So it's similar to the similar presentation to oligohydramnios. You won't get the lungs, they won't be able to develop properly, but you can see that here. If they ask you, if they give you this picture, and if they give you this picture and they ask you, what is the deficit? What is the problem? It's the pleural peritoneal membrane. Now this is different here because this is eventration. Now it's not completely patent, right? It's not a hole. The membrane is still there, but you don't have the musculature. So because the musculature is not there, you can't. The intestines are going to go up into the thorax as well, but you're going to still have the membrane. So make sure you can differentiate if there's a membrane problem causing a herniation versus just the muscular problem that's going to cause this eventration. So what they like to talk about is this paroxysmal respirations. So when you take a deep breath in, your stomach kind of swells out, right? Well, with these babies, when they take a deep breath in, their stomach kind of goes concave inward, and that's because the guts are going up through. So you get the negative pressure. You're supposed to bring air in, but it actually sucks the guts up into the thorax. Okay, now we talked about that air bubble with the kids with the TEF. This is just a normal air bubble. Sometimes you just swallow a little bit of air and you get this bubble. So remember, when you get that TEF, it's going to be a much larger bubble because the end point, the distal portion of the esophagus is coming directly off the trachea. So you have to fix those TEFs surgically around the first week of life, or unless you give parental nutrition until you can get it fixed. Okay, so let's go through some clinical anatomy. Remember, so if the lungs end here, right, you still have this area. This is the pleural, in between the pleura, in between the pleural membrane. So what happens here, especially when the patient's standing, you can get fluid accumulation. This is the most dependent point or the lowest point. So we talked about this again in CPR1. So if you get this here in this costodiaphragmatic recess, you're going to have to remove it with the thoracocentesis. So the point they were trying to make here is you can see that this comes to a sharp edge on this right side. That means everything's okay. Over here, they call this blunting. And the point is that it gets fuzzy right here. And that's because there's fluid development. So you're going to have to go in with a needle and aspirate this fluid out. And if you remember this, remember 6 to 8, 8 to 10, 10 to 12. So you go from 6 to 8, mid-axillaries 8 to 10, and paravertebrals 10 to 12. But the point is you want to get the fluid out at the lowest point, right? But you don't want to puncture the lung. So there's about a 2 rib gap here that you could try to get a needle in and get the fluid out. Now, a pneumothorax, there's some different kinds. A spontaneous one, they like to talk about this ruptured bleb. And this happens a lot in teenagers who are growing. It's not as much of a medical emergency as a traumatic pneumothorax. Now, that's going to involve some sort of penetrating wound into the thorax. And what ends up happening is it ends up sucking air in, but air can't get out. So you get this pressure on one side that's going to cause a lot of the organs to shift to the other side. And you can see that here. So when you talk about a tension pneumothorax, air goes in, but air can't get out. So it's going to end up shifting everything over. And one of the buzzwords you can look for here is this mediastinal shift. You can see everything. It's coming in on the right side and it's shifting all of the organs to the left. And when you look for this, what they say is there's tracheal deviation, and this is the trachea, and you can see it deviating to the other side. So this is a medical emergency. You have to go into the ER and get a chest tube, and they stick a chest tube in here, and they basically pump all the air out to make the organs go back to where they originally were. So remember, yeah, the trachea is going to deviate to the other side. And you can see that here, like if you're trying to identify what's going on here, first of all, you should notice that the heart's on the wrong side, right? And why is that? Well, the lung is collapsed right here. You can see, obviously, this whole blackened region, you don't see these normal lung markings right here. So the point here is that all of this black area is due to this collapsed lung right here. Now, also, you can see that the trachea, this kind of little shadowed area, it's shadowed because it's hollow, because air goes in. So it's shifted to the right side. So there's a pneumothorax on the left, shifting all the organs to the right. You need a chest tube. It's actually opposite of this picture, right? So this has the air coming in on the right. This has the air coming in on the left. So you get this trachea deviating to the opposite side. I put this in from first aid in case you want a little bit more understanding of it. But again, you can see this trachea right here deviating to the wrong side. The heart's being pushed over, and then there's the collapsed lung. Okay, so this Pancoast tumor is just, it's one of those things you could kind of use as a second order question. You could talk about where the Pancoast tumor is and what's it affecting. So obviously, you know, if you get one of these Pancoast tumors that's affecting the right recurrent laryngeal, remember, anytime you hear recurrent laryngeal, you're thinking hoarseness, right? And then you can also get what's called this thoracic outlet syndrome. If it's at the apex here, it can prevent blood flow to the upper limb. It's just basically an outlet obstruction. What they really like to talk about is this Horner syndrome. So a Pancoast tumor can cause it. It's going to cause compression of this sympathetic chain that runs along here, along the vertebrae, paravertebral. And if it compresses the sympathetic chain, you're going to get absence of sympathetics. Now, in the absence of sympathetics, you're going to get a parasympathetic response. So I want you to remember that Horner syndrome has this triad. By knocking out the sympathetics, the Horner syndrome has a triad of parasympathetics. So ptosis, the eye's going to kind of droop a little bit. Anhidrosis, you're not going to sweat. And meiosis is pupillary constriction. So if you see these symptoms, that's classic for Horner syndrome. You're thinking some sort of compression along the vertebrae.
Hi, I have a quick question.
Yes.
On a previous 2 slides before, we talked about the surface landmarks for the pleura, and you also mentioned about chest tubes. I remember in grades, they asked us the question about chest tube, and I got it wrong because those landmarks are not what you use for chest tubes. So could you explain how that works?
Okay, so the landmarks, are you referring to the thoracocentesis? These landmarks?
Yeah.
Okay, so well, these are used clinically because the fluid's going to go to the lowest point. That's where you're going to get it. I know they put in chest tubes a little higher up. I'm not sure if that's just the easiest place to go, or maybe it's the idea that the air is going to go higher than the fluid. But they usually put it mid-axillary around the fourth or fifth rib. So if they ask you about that, I don't want to give you an exact landmark, but I know that I've seen them do it a lot higher up. But maybe that's because the air goes higher than the actual the fluid.
Keep in mind that that slide says this is the best place to access the costodiaphragmatic recess. And so those landmarks are where you can find that recess. But if we're talking about a punctured lung, like Brady said, I've seen them go high up in the ED as well. Like they actually go pretty high.
Like you could see here, right? You could easily go, underneath the axilla here to get all of the air out.
Thank you.
Yeah, no problem. I don't remember them asking us specifically about where to put a chest tube though. Okay, so now that the lung has 3 lobes, the right lung has 3 lobes, the left lobe has 2. I just remember that since the heart kind of goes a little bit on the left side, that's why there's extra space for an extra lobe on the right side. So remember that there's an oblique fissure on both, and then there's a horizontal fissure on the right. So you could see that here. Here's the left lung, and you see this oblique fissure. Here's the right lung oblique, and then you have the horizontal. I think the clinical aspects that they could ask you is, let's say somebody gets a knife wound or gets punctured in the back, right? Note that if you see on the right side, and you can see again, it kind of like fits where the heart would be on the left, right? But if you stab somebody in the back, you're going to affect the lower lobe because this middle lobe on the right is kind of wedged in there. So most of it is on the anterior surface. But if you know right around rib 6, rib 5 is kind of where that junction is of this oblique fissure. And then right around rib 4, you can see this horizontal fissure. But just some of those anatomical landmarks will help you if they ask questions. All right, try this one.
Yeah, we're all getting this concept, so that's good. You're probably going to have this on your exam. Yeah, everybody's saying C. Brady, you want to? Yeah, so the right bronchus is going to be straighter and shorter. SOB is shortness of breath. Sorry, guys.
Right, so, okay, so let's go down and just a little bit more anatomy. So remember the primary bronchus is going to break off the trachea. That middle point is the carina. Secondary lobular bronchus is going to be the next junction, and to the lobe segments is going to be that tertiary bronchus. But that'll help you a lot with the histology if you could differentiate the different bronchi. So when we talk about a foreign object, remember if the patient is straight up, the most vertical of the bronchi is the right. So the right lower bronchi is going to be where a lot of, if they aspirate some sort of, or swallow some sort of object, you can see here it's stuck in the trachea in this child, this coin or whatever. But if it does go into one of the bronchi, it goes into the lower right one. So that's an easy question you get right. Put a star on this slide. Just make sure you know these. I think what helps me out is if you tie the location, like the bronchopulmonary nodes are the hilar nodes, so, or the carinal nodes, the tracheobronchial. So if they ask you, what nodes do you find at the carina? That would be tracheobronchial, right? So you'd find those here, or inferior tracheobronchial. So make sure you can lay these out and you have a landmark for them as well. That'll help for the exam. All right, try this one. Yep.
I was gonna say, how
I have
about
a quick
the rest? Like, how would they ask us questions about like the rest of the nodes? Because I know in IMCQ they simply just ask us the hilar or cranial, which one is the node. But how about the rest?
That's what I remember for the exam, actually. I remember them asking that specifically.
Yeah, those two are the most important ones.
And they're the
exam.
easiest to get mixed up too. So make sure you put the landmark with them. All right, try this question.
I have a quick question from like 2 slides before
Sure.
this one. What is the difference between the atelectasis and hypoplasia?
Atelectasis is the, so if you get some sort of blockage in the lung, everything distal to it is going to collapse. So we assume that the lungs normally form. You can get atelectasis with anything, with some sort of obstructive pulmonary problem or pneumonia. It's just that pressure gradient. If you plug it up, then everything distal to it's going to want to contract. Pulmonary hyperplasia is something that happens embryologically, and it's just the incomplete formation completely of the lungs.
And atelectasis is alveolar collapse.
Okay.
So you're actually getting the alveoli that are retracting and they can't open back up. So when you're talking about the plasias, you're talking about the organ as a whole.
Thank you.
Yeah, and it's more developmental versus atelectasis, which is a pathology.
What is CXR?
Chest X-ray.
ABX is antibiotic. You know which questions I write because I put a lot of stuff in there. Okay, most of our choices are going towards C, which is correct. So when you see a consolidation, which on an X-ray, it's really just going to look opaque. It's going to be very, very bright, very opaque. That's a consolidation. That's pneumonia.
I'll try to point it out, but it makes it look hazy, but we'll get to it. Yeah, look here. So I would say that this patient probably may have bilateral pneumonia, but you can appreciate how much worse it is on the left, right? You could see the heart shadow here, but look how hazy this is. This is because of the consolidations, right? You're getting fluid in the alveoli. That's basically what pneumonia is. But when we want to differentiate, make sure, because you can get pulmonary edema in the alveoli, meaning which is characteristic of pneumonia, but you could also get this pleural effusion. That's what we talked about with the costodiaphragmatic recess, right? So that's different. That's in the pleural. When we talk about pneumonia, that's actually in the alveoli, okay? You can see that here. And that's why there's such a big issue with oxygen exchange, right? You don't want to have to get oxygen through fluid, right? You just want to have that very small interalveoli barrier so that you can get oxygen exchange properly.
Can we go back to the first question and like talk about the other answers, please?
Which one?
Can we go to this question? No, this question and
this one.
Yeah, and can we talk about the other answer choices?
Sure, okay. So dark region of the lung. So if it's darker than it should be and you don't see the lung markings, maybe that could possibly be that could be like a
pneumothorax.
Pneumothorax, thank you. Yeah, pneumothorax, right? Because it's really dark, and that's because the lungs collapse. Collection fluid at the base of the lung. Yeah, I mean that could be some sort of pleural edema, but it's not specific to the alveoli. Like the alveoli should, like in the picture, you could see these consolidations kind of around the alveoli. And then blunting of the costodiaphragmatic recess, remember, that's more of a pleural effusion. But consolidation is a buzzword for for pneumonia, right? So you don't see it. It does look like it gets a little bit worse towards the base, but it's not. You wouldn't just characterize this as consolidation at the base of the lung. You can get edema of the lung that's not specific to the alveoli. It's more advanced, but for right now, just remember that the edema we're talking about, the pneumonia, is specific to the alveoli. All right, let's go through some histology.
Okay, we have answers coming in slowly but surely. It seems like most people are going with B, which is the correct answer. It contains elastic fibers, so we'll touch on that. You can go to the next question, Brady.
All right.
So going through histo, I put stuff on here that I think you really need to focus on. I didn't put everything in here, but I did hit the points that I remember as being really imperative that you look at. So when we're talking about the trachea, this is the initial part of the respiratory system, or going into the lungs. You still have the oral cavity, nasopharynx, and everything like that. But we have respiratory epithelium, submucosal glands. This is made of hyaline cartilage. Remember, the big thing is identification. And the big thing with the trachea, you see the cartilaginous C rings, and at the back, you have this kind of opening there. And this is the trachealis smooth muscle. So this is a gap in the ring. And this is where you're going to find this bridging the esophagus. That's important. I remember that being a thing on our exam. So when you're looking at this, I grabbed this from Google. You have this C ring here. You have the trachealis smooth muscle here.
I don't think we see what you're pointing at. Yeah.
Oh, I'm sorry, guys. I will annotate again. Thank you for letting me know. Now let me move that. And then annotate. Thanks for letting me know. Okay, so we have this C ring down here. We have the trachealis smooth muscle, and then you have the esophagus associated with it. So trachea is one of the more easy ones to identify because of those C rings. It's very characteristic of that area. But you probably should know that you have hyaline cartilage. You can also, if you do a cut like this, you can see the glands right here. So anything that can identify this area is really important. So make sure you can understand that.
And I think that the important thing about the histology is for each different section, what makes it unique, right? So you don't necessarily need an exhaustive list of all the characteristics of it, but some things make each section unique. And I have a slide coming up that's from lecture that should help with that.
Okay, cool. And then the bronchi, again, I put it on here. Can you differentiate each segment if you put side-by-side histo slides? So in the bronchi, know that you have a primary bronchus, extrapulmonary, and then you have intrapulmonary. So you do need to make sure that you can differentiate between the two. There were so many questions on the exam with a clinical presentation. I knew exactly what part of the respiratory system they were looking at, but then you have to go and you have 5 or 6 images and you're like, okay, which one corresponds to what the actual thing is talking about? So make sure that you do that. So of course, how do you differentiate? So this has the cartilaginous plate. So remember, the trachea had more of like the C rings going down with kind of the interruption in the back for the trachealis muscle. This one has numerous cartilaginous plates. So that's a big thing. So some functional things spirally oriented smooth muscle to regulate the airway diameter. That's really important, so make sure you understand that. And of course, you have respiratory epithelium, which that's your big epithelium in this area until you get to a certain point. You can get the next one. Okay. So respiratory epithelium in the conducting part of the respiratory system, make sure you do understand that and make sure you understand what is associated with the respiratory epithelial cells. Biggest thing, Cartagena syndrome. You have an entire slide on this. I just put a little snippet here because this mucociliary escalator is what is the beating motion of the ciliary, and that's what keeps it going. And in Cartagena system, you don't have that motion. That's why you are getting this buildup, because this mucociliary escalator is defective. So you have one of those motor proteins that's defective. You can't get the mucus out and you get the buildup.
And
for the, go for
so
it.
I just wanted to point out, for classically for Cartagena syndrome, if you put all of the pieces together, so you have a cilia defect, right? Specifically the dining arm, okay? Those are buzzwords. But then think in your mind, if you have a cilia problem, what are you gonna get symptomatically? So if you have a cilia problem, you, like Lindsey said, you don't have that mucociliary escalator, you can get respiratory infections. For men, they're sterile because the sperm, the flagella, have that's important. The cilia is important, so that's another thing. And also Cartagena syndrome is the disease where you get sinus inversus, so all the organs are on the opposite side. And you might ask why, and the reason is embryologically the cilia are important in directing the organs where to go. So without the cilia, you can get those classic symptoms. But if you just remember that it's the cilia problem, you can kind of piece together the symptoms.
Yeah. So with these clinical correlates, make sure you do know what is changing here. So in chronic bronchitis, you have the thickened basement membrane, you have the hypertrophy of the smooth muscle, and if you increase glands, they can put one on in the vignette and ask you what would you expect to see, or they can just diagnose the patient for you, ask what do you expect to see, or they could give you the presentation and then diagnose it in your head and what do you expect to see. But you need to know this. That is really important. So on examination, and this is just for your purposes only, this is just how you're going to identify in the vignette that this is chronic bronchitis. You have the wheezing and the cyanosis. So this is the blue bloater. And then I think Brady has a slide on the pink puffer in a bit, but this is how you're going to diagnose the patient. And then the metaplasia, I just put this on here to jog your memory. Every time they can talk about metaplasia, they're probably going to talk about metaplasia. So I just wanted to bring your attention to that. So it's columnar to squamous metaplasia. So I circled that right here.
Remember, characteristic of metaplasia is that it is reversible. Dysplasia is not reversible. That often leads to cancer, but metaplasia, if you stop the insult, you can you can reverse it back.
Mm-hmm. Okay, bronchioles. This is one of those things where I wanted to make sure you guys are being able to identify the different ones. So first, the epithelium, you have ciliated pseudostratified columnar, and then this is an identifier, goblet cells in the larger, and then club cells in the terminal and respiratory bronchioles. So here, this is more of a terminal bronchiole. This is the respiratory bronchiole. So smooth muscle is now replacing the cartilage. So where you had the bronchi, the trachea, and the bronchus, that had the cartilage. Now we're transitioning and it's more smooth muscle. So this is going to be how you're going to differentiate between different parts of the respiratory system as you move down the system. So bronchus or bronchiole. So you can look at it for a sec. You don't have to answer it. Just kind of notice the differences between the two, and we'll go over it on the next slide. Okay, we can go ahead and move. So I just pointed out a few things here. This is going to be your bronchiole. How do we know this? Well, first of all, you don't see any cartilage around here. All of this is going to be
Lindsey,
your, yeah.
Annotate it.
Oh, I'm sorry, guys. So all of this is going to be your smooth muscle right here. You're not seeing any cartilage associated with this bronchiole. Whereas on this side, this is our bronchus. So you have presence of glands. So you also don't see glands here. You have presence of glands. You have these cartilaginous plates. You have this thick spiral smooth muscle surrounding it. And so the big things, it's that cartilage and then the glands for bronchus versus bronchiole. So make sure you can differentiate those. Okay. This again, just wanted to point out, make sure you can identify if there is a change in the epithelium that you know what it is. So hypertrophy and hyperplasia. And then of course, treated with a beta-2 agonist, the albuterol, that's the big thing with this. I just wanted to make sure to point that out. Okay, now we're getting deeper. So we have alveolar sacs alveoli. Yeah, so you do have macrophages associated in this area, and you can see them in here. So you might get a slide like this, and it points to something like this, and you have to know, okay, that's the macrophage, and distinguish it between the resident cells in the area. But make sure, you know, we had a question about this before, type 1 versus type 2. Type 1 is going to be a little more flat and squamous. Type 2 is more cuboidal. So make sure you are able to identify in this area the different cell types and what's going on here. Okay, thin portion versus thick portion. I wanted to put this on here because there is a slight difference. The thin portion, of course, is going to be the most effective blood-air barrier, and it's kind of intuitive because you don't have as much barrier against the diffusion, but there are a lot of similarities. So you still have the surfactant, you have the type 1 pneumocytes, you have the fused basal lamina of the type 1 pneumocytes and the capillary endothelium. So this is very important. And then the thick element has connective tissue elements. So make sure that you can identify. So the thick element is going to be more here than here. Okay, alpha-1 antitrypsin, you have, I think you have an entire lecture or DLA over this, or it's talked a lot about in subsequent lectures, but I did want to point this here because they do point this out. So it increases your risk of COPD, and COPD is an umbrella term. So emphysema is under that umbrella term. So they can put emphysema or COPD, and either one of those answer choices could be correct with respect to increasing the likelihood of in alpha-1 antitrypsin deficiency. So just understand that. But the thing here is it's the elastase that's destroying the elastic fiber. So alpha-1 antitrypsin is going to counter this, I believe, if I'm not mixing the terms up.
I have a couple of slides coming up.
Okay, cool.
Yeah, no worries.
So AAT normally inhibits the elastase, and when we have deficiency, then that would like eat out the elasticity of the lung, right? Which causes
exactly.
And the neutrophils are what secrete the elastase. So the alpha-1 antitrypsin is to counteract the neutrophils, so you can break down the elastase before. So people that smoke that have a deficiency in alpha-1 antitrypsin are more prone to getting pulmonary problems.
Yeah, and then the reason over here for you're getting those pulmonary problems is you have the dilated airspace, so you don't have that area for gas exchange. That's the thing, and remember that the interalveolar septum has those elastic fibers, and that's what's being affected by the elastase, and so that's why you're getting the lung disease. That might, yeah, that's my last slide.
Okay. Now we'll get into some of the more of the physiology stuff. I know some of these equations are a pain, and they're not as intuitive as the cardiac stuff, right? So, but I think for the most part, granted, you don't have scratch paper, right? So I think if they give you some sort of equation similar to this, as long as you could, it'll be straightforward. They'll give you the variables and you just kind of plug them in. But the importance of Fick's law is that the blood gas barrier is inversely proportional to the thickness, right? That makes sense because the thicker the barrier is, the harder it is to get oxygen across. So that's what they're trying to get across with Fick's law here. And then we're going to hit this over the head as many times as we can. The whole point of the type 1 and type 2 pneumocytes. Remember, type 2 pneumocytes are going to be making that surfactant. And again, here, you want to remember that this DPPC is the major component of surfactant. Remember, it comes primarily from this phosphatidylcholine, and then it makes the DPPC, and that's what's going to make up surfactant. I put a star on this slide. When you go to the histo stuff, hit this slide first and then start looking at the pictures, because you can see here, you see that the conducting zone stops at the bronchioles. Once you hit the respiratory bronchioles, you're into the respiratory zone. Conducting means air's just going through, you're just conducting it down. Respiratory means there's actually exchange of oxygen, right? So why would you need cartilage rings here? And that's because they're bigger airways. They need to stay open, right? So these bigger airways are going to have those cartilage rings to hold them tight. What's another reason? Why would you not want cartilage rings down here? Well, because you have to have gas exchange, right? You don't want to have to go through cartilage when you're doing gas exchange. Goblet cells, those are going to be important in the conducting zone. Why? Because you breathe in dust and stuff. So if you get that, you need the goblet cells to make mucus so you can cough it up. So a lot of these are intuitive. Make sure you know the elastic fibers go all the way to the end. You want that elastic recoil effect because when you're breathing out, it allows the alveoli to expand and contract. So try to wrap your head around these, and then you can go in and you can define things, because they can give you a picture. If you see it's a goblet cell, you know you're in the conducting zone, right? And so follow those. And I pulled this from first aid. It's a little more graphical than the previous one. They have club cells. Remember, club cells are going to secrete a certain kind. I don't think they dive into it too deep. It's like a certain type of surfactant. It's a little bit different. Don't really worry about it, but that's what they do. And then as you get down here, you get this thinner membrane and you get the type 2 pneumocyte. So you can see how it works here. Now, when we talk about the diseases, we'll get into two categories. You have the obstructive disease, which is the problem with the conducting zone. You can't get air out. That's what you need to remember for these conducting diseases or these obstructive diseases. When you're talking about the restrictive diseases, you can't get air in, talking about like pulmonary fibrosis. So that's going to be a problem with gas exchange, and we'll get into that further. Again, we've already discussed this mucociliary escalator. It's a unidirectional flow. So you have the cilia is going to go one direction. That's to get everything up and out, any dust or particles or whatnot. And then when you smoke cigarettes, it's gonna destroy those cilia. It's gonna make increased mucus glands to fight off the smoke, decrease cilia. So you're prone to getting chronic bronchitis. So Boyle's law is pretty straightforward. So all it means is that the pressure and the volume are inversely proportional. If you squeeze down, if you put more pressure on like right here on this little area, you're going to have decreased volume. That's it. That's all you need to know. Decreased pressure means increased volume. And those correlate. We'll look at an image in a second, how it correlates to the lungs. But you just need to know that if you put more pressure, there's going to be decreased volume. Charles went into it a little bit deeper because Boyle's law assumes that temperature stays the same, but Charles went into it deeper, assuming that there's a temperature variable. Don't worry about this too much, just understand Boyle's law. Okay, so we talked about this negative pressure thing. There is one little concept you want to bring into this as well. So when the diaphragm contracts, you're going to get a negative pressure in the pleural space, and that's going to cause a negative pressure in the lungs. It kind of makes sense. If you pull down on the pleura is going to pull down on the lungs, but they do actually get an independent pressure when you contract the diaphragm. And it comes into play when you have some sort of pleural effusion, maybe that can mess it up, or some sort of penetrating wound. And you can see that here, right? So if you bring air in, you're going to get a negative pressure between the red and the blue, and that's going to cause a negative pressure in the lungs. Therefore, it's really easy to get air in. Works the opposite way too. Positive pressure pushes air out. Okay, I think this is just a summary. You can read this in your own time. So let's go into some of the breathing cycle. So one of the things that's important to differentiate that transpulmonary pressure, these are kind of just definitions that you want to know, but you just know that there's a difference between the pressure in the airway or the alveoli and the intrapleural pressure, and you can measure that pressure differential. And you can see that here. For example, immediately when the diaphragm starts to contract, you're going to get this negative pressure in the intrapleural pressure, and then after that, you're going to get a negative pressure here that's going to in the lungs to actually allow air in. It seems like a simple concept, but they go into it in lecture for whatever reason in pretty significant detail. So I figured I'd put it in. Okay, so when we look at this, we're gonna use Boyle's law, and it's pretty straightforward. You increase the volume, you take a deep breath in, you're decreasing the pressure, right? Or conversely, when you're decreasing the pressure intrapleurally and in the alveoli, air is gonna come in. That makes sense, right? So you're gonna breathe air in. And then after, when you increase the pressure or relax the diaphragm, the volume's gonna go down. So you're gonna decrease in volume, increase in pressure, and air is going to go out. So this is inspiration and expiration. So this makes sense, right? We would expect volume and pressure to go completely opposite. They're inversely proportional. If you increase the volume, you decrease the pressure. If you decrease the volume, you're increasing the pressure.
Sorry.
Sure.
For inspiration, the flow. Why is it a deflection, not a
That's just how they set it up. Yeah, that's just how they set it up. Just know that down is breathing in, up is breathing out. That's just how they graphed it out.
Okay.
Yep. And then this is in words kind of what happens, but just remember that pleural pressure, you have to get a negative variable there before you get the negative pressure in the lungs to inflate. This was a little tricky for me. So the idea of compliance is inverse to elasticity or elastic. Or elastance. So elastance is going to be how much it can recoil, how much it can come back, how elastic it is. Compliance is going to be how much it can hold, right? So the compliance or how much it can hold is inversely proportional to the elasticity or how much it's going to come back together, right? So that makes sense. What kind of got me is this whole idea of hysteresis. And the idea is that when you take a when you breathe out, you get less pressure, but when you breathe in, it should be together, right? But you have different variables that make this pressure gradient that you have to overcome when you take a deep breath in. Then that's why you get an increased pressure. But this lag is due to surface tension. And once you overcome these extra variables, when you think about it, when you breathe out, it's very passive of a process. But when you breathe in, a lot of stuff has contracted and it's smaller. So not only do you have to breathe in and take the air in, but you have to overcome these variables as well. So it takes a little bit extra amount of pressure or pressure difference when you take a deep breath in than when you take a deep breath out. But that's all you need to know about this. But mostly just know that the compliance or how much it can fill is inversely proportional to how much it's gonna, how much elasticity it has. Okay, so this is really important. This is the whole principle of surfactant. So I don't know if you consider it, well, we'll see. Like a paradox or something like this, but it is tricky when you watch these videos on YouTube. It seems counterintuitive, but with increased pressure, with increased radius, you're going to get decreased pressure, as you can see here. So if you accept this, that's my dog snoring in the back, so don't mind her. If you get increased radius, you're going to get decreased pressure. Okay, so when you look at it here, this is the problem, and this is why the body needs surfactant. This has an increased radius, therefore it has a decreased pressure. This has a decreased radius, so it has increased pressure. That presents a problem because if there's air in both of these, since this smaller cavity has an increased pressure, the air is all going to want to go to one central place, the largest place. that means this alveoli is going to collapse. We don't want that. So that's why the body makes surfactant. Now, if you look at this is what I was going to talk about. You can watch this in your own time. It's really quick. You would think if you turn this valve, that all the air in this big balloon would go to the small balloon. That's actually not what happens. So what actually happens when you turn this valve is the air that's in this small balloon actually goes to the big balloon, and this one collapses. So this is the whole thing in the lungs. What if these were alveoli, right? And you had air here and air here, where all the air would go from the purple balloon to the orange balloon, and then this would collapse. You don't want that. So the body makes surfactant, and what the surfactant does is it counteracts it'll decrease the surface tension. Now, this surface tension is gonna be what makes this alveoli want to collapse. So you're gonna get an opposite pressure there by the surfactant that's gonna hold it open. And the smaller it is, the more the greater the decrease in pressure by the surfactant, because the molecules can come together. And I have a slide coming up. So yeah, one more slide. The surfactant activating agent. I think, oh, sorry. This is just the summary. I guess I put it in. You can go through this on your own. Yeah. I put this in here because I didn't think it was terribly important, but we did have a question on it, asking us to differentiate these SBA, B, and C, and D. So just go through that on your own time. Just make sure you can identify those. Okay, so let me see. I did pull this up so I could show you. Let's try this. So if you have the alveoli, right? Let's see if it's gonna come up. Or not, I thought it was. If you have, well, that's not right. Okay, I tried.
Hey Brady, quick question.
Yeah, sure.
If you go to the slide right before this one.
Yeah, 1 second. Yeah.
This one, do we need to know specific protein?
Yeah, that's what I was saying. You want to definitely differentiate these. It doesn't seem high yield, but they did ask us a question about the different proteins, yes. Okay, so I wanted to draw this out for you guys, but for sake of time, I'm not going to mess with it. So as we said, the smaller the radius, the increase the pressure. So the surface tension is going to be the highest when the alveoli is collapsed. All right, once you take a deep breath in, the alveoli expand, you get an increased radius, so you're going to get a decrease in pressure. That's fine. So the problem is when the alveoli get small, and they get that increased pressure, so they get a decrease in radius and they get an increase in pressure. How do you prevent them from collapsing? So that's at point 3. At point 3, they're the smallest radius and they have the highest pressure. So how do you prevent it? Well, you can see here that at that point, the surfactant molecules bunch together, right? They completely surround it. So what I was going to draw for you guys, if you imagine, the alveoli, right? And it has vectors going inward, right? It's going to try to collapse it. Well, the surfactant puts vectors going completely opposite to keep it open. So it's important when the alveoli is the smallest and it has the increased pressure, that you get a bunching up, so they completely surround the alveoli, right? So when the pressure wants to collapse, the surfactant counteracts the desire to collapse, right? So that's why they are bunched up. But when the alveoli expand, you get an increase in radius, so you get a decrease in pressure. So they're able to spread out. It's not that important for them to be able to prevent the lung or the alveoli from collapsing just because they're larger. They have a larger radius and a decreased pressure. So just remember, point 3 is the most important point, because you want the surfactant to bunch up so that you prevent the lungs from collapsing. This is just a really important slide conceptually, but this is why children, neonates, premature babies, they get acute respiratory distress syndrome because they don't have enough surfactant, right? So at this point, when these alveoli are small, they don't make enough surfactant to help counteract the desire for the alveoli to collapse. So the alveoli collapse and they're not able to breathe.
So then number 1 would be the perfect scenario where they don't collapse.
Yeah, number 1 is just everything spread out. So you have so much air in there that the air is actually pushing outward, and so it's not going to collapse because it's expanded. It's like after you blow up a balloon, it's not going to collapse because there's so much air in it. But once the balloon's small and there's increased pressure, that's when you want the surfactant to kind of like bathe the inside of the alveoli, because it's going to counteract the pressure. It's going to decrease the surface pressure, meaning it's going to counteract the idea that the alveoli is going to collapse. So
it also, and I put another slide on here too, it also prevents hyperinflation. So at this very top, this point right here, which I have a slide on because I wanted you guys to make note of that because they do ask about it. Point 1, you're max inflated, and point 3, you're max deflated. So at point 3, you prevent atelectasis. At point 1, you're preventing hyperinflation. So conceptually, to understand that as well, but they love to test point 3 because they'll put that surfactant graph with it, not necessarily the cartoon one, but the one that's a little more, it looks like it's from a research article or something. In your notes, they'll put that on there and they'll say which point on this graph would represent this. And so that was my big point here of adding this additional slide to this concept is, do you know where it's inflated? Do you know where it's deflated? And can you relate that to the distribution and the density of the surfactant molecules?
You said 1 was to prevent hyperinflation, right?
Mm-hmm. Yeah. Because you don't want to overinflate the lungs either. So at the bottom, when it's deflated, you don't want alveolar collapse because then the pressure to overcome that collapse. Yeah, you can go ahead and go to the, oh, you're coming back here. The pressure that you would have to overcome if you collapse is very great. That's why in those lung diseases, you can't get air in because there's too many forces opposing getting that air in. But if you overinflate, that's also not good. So you can, you teeter back before that. 2, 3, 5 aren't as important, honestly. They're going to test the extremes. But you can, if you look at a graph on this is just another graph that in your notes, knowing at which point in this graph means what. So if you go up, this is inflation. So 4, 5, 1, that's inflation. 1, 2, 3 is deflation. So that's basically the concept. If you're looking at the numbers, that's what you need to understand is which part of the graph are you inhaling, which part are you exhaling, max inflated, max deflated, and what it is related to the density of the molecules there.
So just think about it, like the pressure in the alveoli, they're the smallest. So the pressure is the greatest when they're the smallest right here. So as you take a deep breath in, getting decreased pressure, all the while the surfactant molecules are spreading apart. They're not as important, right? Because they're most important to decrease the surface tension at the point when the alveoli have the most pressure down here. So as you inflate, they spread out, everything's fine. Then as you deflate, they kind of come together because as you increase pressure, you increase the need to counteract that pressure. So as they get smaller, the surfactant is going to push outward to help prevent it from collapsing.
Yeah,
and
we
as we
talked
said
about
here,
that.
yeah, so inspiration all the way up and then expiration. But if y'all look at that YouTube video, it just kind of like paints the picture, right? When you turn the valve, the air from the smaller one goes to the bigger one. So that's the whole idea of surfactant.
I have a
It's
quick
small.
question.
Yeah, sure.
Like at point one, your volume would be the highest, right?
No. I'm sorry. Yes, you're right. At point one up here, yes, the volume's the highest. Yeah.
So why is the surface tension the greatest then?
Surface tension is the greatest at this point.
Because I'm
When
looking
it's
at the y-axis, so I'm kind of confused with the.
How come on the graph it's the number?
Oh, you're decreasing surface and
You know
let me
what I
see
mean?
what the x-axis was. I have this on my thing.
Wouldn't surface tension be the highest when you're maximally inflated because the lungs want to collapse back down? And then
Yes, I believe that the elastic recoil force is the highest at max inhalation. That's why surface tension is the highest
Yeah.
at 1.
Yeah, and that was the hyperinflation point I was making, because you want to make sure that if you hyperinflate something, if you overinflate a balloon, it's going to pop, right? You don't want the lungs to pop. And so you need to increase that surface tension. So it can increase surface tension or it can decrease surface tension. And the way it does that is the density, the distribution of the surfactant molecules.
Okay, so number 1 is the highest surface tension and 3 is the lowest surface tension, right?
Yes, because
Yeah,
the
sorry about
surfactant
that.
is
Yeah.
lowering the surface tension at 3.
Yeah, right. That's the point. The point is that I guess I wasn't actually incorporating the surfactant into it. The reason that 0.3 has such a decrease in surface tension is because the surfactant molecules come together. If you didn't have surfactant here, this pressure would be much higher and it would cause it to collapse. So this graph is correlated to the fact that the surfactant molecules are what they are. So the reason that the surface tension is so low at 3 is because they come together. Now, obviously in the picture I showed you like this, there's no surface tension here. So the pressure, there's no surfactant here. So the surface tension here is much greater than here, making it want to collapse. But obviously here, when you add the surfactant and they're bunching up like that, it's going to decrease the surface tension. Sorry, thank you for pointing that out.
Sorry, so the graph is showing what happens after surfactant acts on the alveoli.
Yes, that's right.
Okay.
Yes, that's why it's so decreased, because it makes sense, because at this point you don't want a lot of pressure, because if there's pressure here when the alveoli are smallest, then everything's going to collapse. So you keep the surface tension low at 0.3. But if you remember like the micelle that forms, it's kind of like surrounds the cell. That's what the surfactant does. It surrounds the inside of the cell and it makes the surface tension very low.
Awesome, thank you.
Brady, there's a very important concept about number 1. Like we need surface tension there, because if the surface tension is going to avoid the alveoli to pop out.
Right,
So that's why.
Right. That was my
Lindsey was
hyperinflation thing.
Yeah. And by spreading out the surfactant molecules at this point, that's actually increasing the surface area. So the further you spread these out, the more surface tension you're going to get, and that's going to prevent you from hyperinflating. And then as you get smaller, they're going to bunch together, and that's going to decrease your surface tension.
I think I got confused again.
Okay. I'll try to point it out. Okay.
So can I tell you what I have, and then you
sure.
let me know if that's. So we said, so at 1, we have a higher tension below surfactant.
Yeah,
Yes.
a higher surface tension, yeah. So at 0.1, the alveoli is going to, sorry, hold on. The alveoli is going to be the largest, right? So the surfactant molecules are going to be further apart, right?
Yeah.
So then here you're going to get an increased surface tension, and that correlates to the fact that the alveoli are far apart. And the reason you want increased surface tension is because as they go further apart, you're preventing, and the fact that you're adding air into it and stretching it out, you're preventing hyperinflation, right? You want increased surface tension. Now, conversely, when at point 3, it's much smaller, right? So you're getting, the alveoli, because it's small, you have a decreased radius and you have increased pressure, okay? So you're gonna get this formation. Now, what we do to counteract this pressure, and this is where I think I might have lost y'all, and thank y'all for clarifying. When you get this, the alveoli, you're gonna get, see the surfactant molecules are close together, right? Compared to the other picture. And by doing that, by having those alveoli, the surfactant molecules close together, you're gonna decrease the surface tension.
Okay.
Does that make sense?
Yeah.
And why do you want to decrease surface tension at this point? Because you don't want the alveoli to collapse. Okay, I hope that helped. Oh goodness, let's see. All right, try this one. And yes, Susan, so the idea that bringing all the surfactant molecules closer together is going to decrease the surface tension, right? So it's going to decrease the ability for the alveoli to collapse on itself. That's the idea. So the closer the surfactant molecules are to each other, the lower the surface tension.
So we're getting a lot of choices for D. Yeah.
Yeah, so we're going to go into a little bit of physiology of this, but this is an obstructive lung disease. And so one of the concepts here is this equal pressure point. So we all have this, and it's, you know, it's a point at which it keeps the, being that it's so close to the trachea in the conducting zone, you're actually keeping the bronchi patent, right? So what happens in people that get COPD and some sort of obstructive lung disease, you're moving this equal pressure point closer to the alveoli. And what that does physiologically is it makes it close off, right? So you're going to get, classically, you get this air trapping, okay? And so they're going to get this increased total lung volume, but they're not going to be able to get it out. That's forced expiratory volume that they're going to want to expire is going to be lower compared to their total lung volume. And you'll see that. So the idea is that when they purse their lips, they're bringing this equal pressure point back to where it normally is, back to equilibrium. And hopefully that'll keep that patent to where they can get air out. But that's the idea with pursing their lips, to bring that EPP back to normal.
I have a quick question.
Yep.
From the last question we just did, if we have an alpha-1 AT deficiency, doesn't that also increase compliance of the lungs?
Yes.
Yeah, right. So
like to differentiate between A and D on this.
Okay, let me see. What? Oh, yeah. So even if you had no evidence. So I guess
smoking is more indicative of emphysema, but
well, technically, people with the alpha-1 antitrypsin deficiency, if they smoke, are more prone to getting COPD symptoms. Yeah, I guess I can't see anything that would differentiate this.
So what was the giveaway for this question?
So, okay, so, well, emphysema, when you talk about Well, first off, we talk about the diameter of the chest. That means there's air trapping going on. So you're thinking it's an obstructive lung disease versus restrictive. So that's going to take out, oh, I'm sorry. So, and then, let's see. Yeah, I'm sorry. I didn't actually write this question. My AEP facilitator, co-facilitator
So
did.
I went with the no evidence of hepatomegaly or liver nodules to differentiate from A to choose D.
Actually, yeah, that's a great point. And we'll get to that in a second. One of the classic findings in alpha-1 antitrypsin deficiency is actually that you also get cirrhosis of the liver. That's one of the problems. I forgot about that, but yeah, I have a slide coming up on it. You will get that. So I guess technically that could cancel this one out. So if you're going between emphysema and alpha-1 antitrypsin, the fact that the patient doesn't have any liver symptoms would lead you more to emphysema.
Okay, yeah, there was one of the slides from Margaret's lecture has smoking increasing free radicals, which then decreases your alpha-1 antitrypsin, which is why I got a little confused with it. But thank you.
Yeah, no, that's a good point. Will brought up that the fact that with alpha-1 antitrypsin, I remember it now. It dawned on me, but Dr. Sobring had a good point about that. But I do have a slide coming up on it. Okay, so when we talk about this pink puffer or the classic obstructive lung disease, they're going to get increased total lung volume, right? But they're not going to be able to get it out. That's classic for obstructive lung disease. When you talk about line 2, this restrictive lung disease, they can't get air in. And since they can't get air out, there's not a lot of air. They can't get air in. There's not a lot of air to go out either. So these are two classic examples, the two you're going to want to be able to differentiate from. This was a little confusing for me, but what I try to do is, if you correlate this picture with this, the idea is that the chest wall expansion, or the desire for the chest wall to expand, helps to counteract the desire for the lung to contract. So these are equal and opposite. And what this does is it keeps the lung open, and it keeps it just at equilibrium so that the lung stays open, and you get this functional reserve capacity right in the middle. So if you get some sort of deviation, some sort of injury, maybe a rib injury or something like that, or a punctured lung, this can deviate. Quickly, this dynamic compliance. If you think of asthma as a good example of this, as if you constrict the bronchi, right, and if you constrict the bronchi, you're going to increase resistance, right? So if you're increasing resistance and you're constricting down, then obviously the bronchi aren't going to be very compliant. So you see more of this. They're not going to be able to pull in as much air because you're constricting, but that's the whole idea of this dynamic compliance thing. All right, try this one.
Gunnar says hi.
Hey.
We're getting a lot of answer choices for A. What you doing? Jeez.
Where is Phoebe? Somebody wants a Phoebe shout out. Hold on 1 second. Phoebe. Oh yeah. She was sleeping. It's
She's
Phoebe.
not
She's the one.
happy.
She's the one snoring in the background. There she is.
Phoebe.
Total lung compliance. There you go.
Did you just throw her on the bed?
She's a champion.
It's like, Dad, what are
gotta
you doing
practice.
to me?
All right. So what are we talking about here? Okay. Well, obviously, when you have strenuous exercise, you can get lactic acidosis. Excuse me. So you can get decreased arterial pH. Yeah. So look, when we talk about this curve, this is super important. So you need to remember that a left shift is you're going to want to hold on. The red blood cell is going to want to hold on to the oxygen. So remember, a left shift correlates to the lungs. A right shift, you're going to want to offload oxygen. So that correlates to the tissue. So when you talk about like the previous question, strenuous exercise, you get lactic acidosis, you get hydrogen ions that accumulate in the muscle. So you're basically telling the red blood cell, hey, we're undergoing anaerobic glycolysis. We need some oxygen so we could do aerobic glycolysis. So just keep these separate. Left shift means the red blood cell wants to hold on to the oxygen. A right shift means you want to offload it. So these correlate, and we'll go into that a little bit more detail. This is straight out of first aid, and so you can use this ACE-BATS, right thing, whatever works for you. But we'll talk about some of these in a little more detail. This ventilation perfusion mismatch, it kind of just, if you ventilate, you would think that you get primarily air in the upper lobes. But, if you imagine that the lung is like hanging on by a string, the lower aspect of the lung is able to expand better. So that works out physiologically because as gravity has it, the perfusion is going to be lower in the lung. So this allows the ventilation to kind of like equalize in the lung. But we'll talk about that in a little bit more detail. So the way I do this, remember the volumes are all independent of each other. The capacities are additive. So just write them all out and say which correlates to what. What are these capacities? You have to add stuff to get the capacities. You have to add the volumes to get the capacities. So just make sure you understand what goes with what. All right, let's see. So we're going to talk about this. So one of the defining characteristics of the obstructive disorders is that FEV1 is going to be decreased compared to the functional vital capacity. Now this makes sense because these patients with COPD, they can take a lot of air in and it gets trapped in their lungs, but they can't get it out. So their functional vital capacity, they can actually hold in a lot. That's why they get that barrel chest, right? But they can't get it out. So this numerator is going to be drastically decreased compared to the denominator. Now the difference is that with restrictive lung disease, both variables are going to be decreased. You can't get air in, so therefore you can't get air out. So one of the classic things they can ask you is if your FEV1 to FVC ratio is like 50%, understand that that's classic of an obstructive disorder. They're saying you got a lot of air in, but you can't get it out. All right. With that being said, try this one. No, so the blue bloater is for restrictive lung disease. You're blue because you can't get air in, you can't get oxygen in. That's why you're blue. I mean, the or whatever you want to use to remember it. That's why you're blue. The pink puffer means they can get air in, so they're oxygenated, so they're red or pink, but they can't get the air out, so they're bloated. I'm sorry, they're puffing, and they do the pursed lips. So red means they can get air in, they're oxygenated. Blue means they can't get air in. Chronic bronchitis is an obstructive lung disease. So you would be a pink puffer.
We're getting a lot of answer choices for C.
Right, so this makes sense, right? Because this patient has bronchitis. Bronchitis is an obstructive lung disease. So FEV1 to FVC is going to be decreased. You can get air in, that's the denominator, but you can't get it out, that's the numerator, so it's decreased. This kind of just breaks it down for you a little bit more, but the main thing you need to remember is that they can't get this air out. Their forced expiratory volume in 1 second is drastically decreased.
I have a quick question on the previous slide.
Which one? This one?
Yes. So I know C is the most correct answer, but doesn't the FVC increases as well?
Functional vital capacity. No, it's the functional
No.
residual reserve capacity, because they actually, and I'll make a point to clarify that in just a second. Just give me 1 second when we get there. Because what actually happens is they actually hold on to a lot of air. That residual volume they have is like around 4 liters instead of like 1. So they're actually, it's not vital. They're not getting it in and out. It's just literally sitting in their chest. But I'll point it out on the ground. Oh, this is perfect, actually. So look here. If we look at a normal range, right? So you have this initial reserve volume. You're just under about 1 liter when you don't have any, you breathe out, right? You're about 1 liter. Then you take a deep breath in. That's below this x-axis. That's inspiration. Take a deep breath in. You fill to about 6 liters, and then you take a breath out and you go back to your reserve volume. Now, with obstructive lung disease, you're shifting this equilibrium point, right? So you're starting, instead of starting with just under 1 liter, they're starting almost at 4 liters just in residual volume. So they take a deep breath in, and then that functional, that vital capacity, I guess maybe, let me see something real quick. Functional vital capacity. Oh, so it's decreased. So that must mean from here to here is actually decreased, or the area underneath is decreased. So they do get air in, but if you subtract this from this, it's still less than this. So the point is that they're holding on to a lot of extra air, but they're still, it's not like they can breathe all this air out. So they take a deep breath in, they get to almost 9 liters. They can hold more, they have a barrel chest, but when they breathe out that residual volume, you can see they're not able to breathe a lot of it out. Now, restrictive lung disease is going to cause a right shift. So whereas you're almost at 2 liters in residual volume, they have much less. They're below 0.5. So when they take a deep breath in, they're not getting a lot of air in, so they're not getting a lot of air out. So that's what you want to remember for these. Restrictive is a right shift, obstructive is a left shift. Yeah, right. So this is pretty straightforward. A right shift, you're thinking a restrictive lung disease. So of these, the only restrictive lung disease is pulmonary fibrosis. A, B, and C are going to cause a left shift. Okay, and I just put this in here again. Super important that you could recognize these for the test. Okay, let's get into hemoglobin. This is super high yield as well. Okay, so when you think of that quaternary formation, right, you're putting multiple proteins together to form it. That's what happens here. So you have a ferrous iron in the middle, that's +2, and then you have 4 subunits. Each are able to carry an oxygen. So when you talk about methemoglobinemia, I want you to think of a blue person. Counter that with a person who has carbon monoxide poisoning. They're going to be a cherry red appearance. So these people have a ferric iron here, this methemoglobinemia. And when a ferric iron, a +3, you're going to turn blue because it won't bind oxygen. It has to be ferrous to bind oxygen. It has to be +2. So you see classically, they have these pictures of these blue people. And that's because they're ferric, and so they can't bind oxygen. This kind of just counteracts, you can see the difference is they're pretty much exactly opposite. Hemoglobin being the transportation method of oxygen, whereas myoglobin is more of a storage form. And one of the key characteristics, and this is why you get that sigmoidal curve, we'll look at it in a second, it looks like an S, because you have cooperative binding. As you increase the amount of oxygens that are bound, it makes the subsequent oxygen easier to bind. So if you have 2, it makes the third one easier. If you have 3, it makes the fourth one easier. I have okay, so you can see here this sigmoidal curve, that's indicative of cooperative binding. Now, when you think of 2,3-BPG, I want you to think of tissues, right? You have increased 2,3-BPG in the tissues because 2,3-BPG will decrease the affinity for oxygen. Now, why do you want to decrease affinity for oxygen in the tissues? Because you want to tell the red blood cell to offload the oxygen to the tissues. So by having 2,3-BPG in the tissues, you're telling the oxygen, the hemoglobin on the red blood cell to release the oxygen into the tissues. So this is a right shift. Increased 2,3-BPG causes a right shift, which is going to cause offloading of oxygen. Remember, that's in the tissues primarily. So they talked about this deficiency, this hexokinase versus pyruvate kinase deficiency. So you learned from glycolysis that if you have 2,3-BPG here and you have a hexokinase deficiency, you're not going to make 2,3-BPG. So that's going to cause a left shift. If you have a pyruvate kinase deficiency, the intermediates are going to back up. So you're going to have increased 2,3-BPG. That's going to cause a right shift. Remember, correlate 2,3-BPG as tissues. 2,3-BPG means offload all the oxygen that you have. Okay, and Bohr effect is similar. But instead of 2,3-BPG, we're talking about hydrogen ions. So same principle. If you have lactic acidosis, if you have increased acid or hydrogen ions in the tissues, you want to tell the red blood cell to release the oxygen. So if you have acid in the tissues or hydrogen ions, it's also going to cause a right shift, which means offload the oxygen. So one more time, right shift means offload, left shift means hold on. Increased 2,3-BPG tells that red blood cell to get rid of the oxygen to offload it. Increased acid, increased temperature, and high altitude means you want more oxygen to the tissues. All right, and Dr. Mpadya put this up on her graph. One of the things that's characteristic is that when you transport the carbon dioxide in the blood, it's in most of the time it's in the bicarbonate form. So you need to use carbonic anhydrase to take the bicarb and convert it back to carbon dioxide before you breathe it out. And same thing here, it's made into carbon dioxide and to bicarbonate here, but it's mostly just to carry it in the blood. All right, this is from first aid if you want a little bit more explanation. So remember that carbon monoxide, these patients are classically going to come into the ER with cherry red appearance. And that's for no other reason than that carbon monoxide actually causes the hemoglobin to look a little bit more pinker, but just converse that to the methemoglobinemia people, which are blue. And the problem with carbon monoxide is it binds to hemoglobin much stronger than than oxygen does, but it's not sigmoidal, it's not cooperative binding. So once it binds, it kind of shuts off the hemoglobin, and you can see that here, there's no cooperative binding. So fetal hemoglobin, if you think of the fetus, it wants to hold on to the oxygen, right? So what it does is it actually has a decreased affinity for 2,3-BPG. So with a decreased affinity for 2,3-BPG, you're going to cause a left shift. And that makes sense because the fetal hemoglobin's going to want to hold on to the oxygen. It's going to want to pull it from mom's blood and it's going to want to hold on to it. So fetal hemoglobin has an increased affinity for oxygen simply by having a decreased affinity for 2,3-BPG. I know that's a lot of words, but if you wrap your head around the idea that 2,3-BPG means get rid of it, then if you have a decreased affinity for 2,3-BPG, it's going to make the fetal hemoglobin hold on to it. So it'll cause a left shift. Now, hemoglobin A1C is just a measurement for diabetes. Since your red blood cells last about 3 months, if you have increased sugar or glucose in your circulation, it'll actually glycate the hemoglobin, that glycation is just a non-enzymatic glycosylation. But what it does is it's measurable. So if you show up to the doctor's office and you say, my sugar's been good, and you've been good for a couple of days, they can actually go back and check from the last 3 months and see how it's been. Because if your sugar's been really high, you're going to have more glycated hemoglobin. So since the red blood cells live about 3 months, you can measure the amount of glycated hemoglobin to see, on average, what your sugar levels have been. The hemoglobinopathies and thalassemias. So when you think of the hemoglobinopathies, you think of this qualitative change, versus thalassemias is more of a quantitative change. So qualitative just means like you're messing up the structure of it. With thalassemias, you're getting a decreased amount of it. Now, sickle cell, what they really want you to remember is specifically this position 6 on the beta chains. They want you to know this whole thing. It's a point mutation, position 6 beta chains. So you're taking this glutamic acid and replacing it by a valine. So you're taking a negative charge and you're making it neutral. What does that do? Well, in the red blood cell, it makes this hydrophobic pocket. This valine does. And when you make a hydrophobic pocket, you're going to end up sickling the cell like this. And what happens, I live in New Orleans, and there's a high population of sickle cell patients here. And these children come in with these pain crises, and you have to give them morphine and stuff just because it's so painful. So when these cells sickle, they end up causing pain crisis. They occlude the vasculature. And sadly, a lot of these patients get addicted to pain medication at a young age, physically and psychologically, just because of the fact that there's such significant pain that they undergo. Okay, so the glutamic acid to valine, like we said before, is a negative to a neutral charge. It's an autosomal recessive trait, and we're going to go into it. So you can see here, this is what happens. This is what causes all that pain. These cells that sickle kind of occlude the vessels, and there is some sort of treatment that they use here. This is an example of it, but it's not the best treatment in the world. But the idea here is, what if you can increase the amount of fetal hemoglobin they have? Their fetal hemoglobin's fine. It's their normal hemoglobin that's messed up. So some of the medications you've talked about, desitabine and hydroxyurea, are used specifically for the fetal hemoglobin. So desitabine causes demethylation. I know this is from way back in FDM. Hydroxyurea causes acetylation. And you remember, if something is demethylated and acetylated, you're going to cause euchromatin. And with euchromatin, you're going to increase transcription. So if you could do this to the fetal hemoglobin, this kind of counteracts the development of the hemoglobin S type of hemoglobin. Now, this is a concept of heterozygous advantage. Some of the endemic areas of Africa where malaria is present, they have a lot of people that are heterozygotes. And the reason is that the malaria life cycle is around 3 months. And people that are heterozygous for sickle cell, their red blood cells don't last as long. So the malaria can't go through a full cycle. So people that are heterozygous for sickle cell are actually protected against malaria because their red blood cells don't last as long. So obviously, if you have a lot of heterozygotes, there's a bigger preponderance for people with homozygous sickle cell to form. Hemoglobin C is a little less common, but instead of going from a glutamic acid to a valine, you're going to a lysine. So you're going from a negative so valine was neutral, you're going from a negative all the way to a positive. So if you do this on electrophoresis, you can see them differentiate to the different areas. So HBS or sickle cell is going to be neutral because it's a valine. HBC is going to be positive. The normal variant is negative. So if you look at that here, if we graph this out, the normal one's going to go the direction of movement. You're going to go, since the glutamic acid is negative, you're going to move across to the positive side. If you have a neutral one, which is the hemoglobin S, it's going to go centrally. And if you have a positive one, it's going to stay towards the negative side. So make sure you know this, because they could ask you on the test the different the different points, and you have to tell which one travels further. And it's kind of just asking you what is the genetic mutation and what is the charge. So thalassemias, you can have alpha or beta thalassemia. Obviously, alpha is going to be reduced alpha chains, and beta is going to be reduced beta chains. So we'll quickly go through this. Typically, you can get alpha globin problems with the crossing over. If you remember this yellow slide, it's kind of a gradient. You really get phenotypic symptoms once you get to 3 or 4. So loss of 3 genes is the HBH, and loss of 4 genes is not compatible with life. That's called BARTs. So just a little point, it's not super high yield, but just in case they ask, if you get this cis mutation versus trans, the cis is worse. And if you, yeah, I put that here just so you know which one goes with. The cis is worse just because if you look here, if you get the cyst from one parent, you're definitely going to get both mutations, versus the trans, you're just going to get one. So just in case they ask, the cis is worse. One other thing, a buzzword with HBH, where you get decrease of 3 alpha chains, mutation of 3, the betas can actually make tetramers. So if they ask you about a beta 4 tetramer, that's specific for HBH. Now, beta thalassemia is one of those classic examples of allelic heterogeneity. That means you can have multiple mutations on the same gene. So this also has this gradient, right? So you can have a minor defect, intermediate, or a major defect, depending on how many beta chains you actually have. So it's very similar to alpha. And one of the things, the bone marrow tries to compensate with this decrease in blood formation by expanding. And when the bone marrow expands, you get this thing called extramedullary hematopoiesis. Or I'm sorry, erythropoiesis. So the idea is like you're constantly churning over, you're constantly trying to make red blood cells to compensate for the decrease hemoglobin structures. So you can see this classic frontal bossing or this extramedullary erythropoiesis that forms. Okay, so treatment you can do. One of the things that's classic for, just be careful in the test, they'll tell you that the child presents about 6 months. But why is that? That's because about 6 months, that's when you get rid of this fetal hemoglobin. And once you get rid of fetal hemoglobin, then you're relying on your adult hemoglobin. So just classically remember that 6 months is an important mark. We talked about that hemophilia already when we did CPR1. That's a bleeding problem. You get a prolonged APTT. Just one thing to add, if you talk about hemophilia A, there's usually a large mutation. It shows allelic heterogeneity, large inversion, versus hemophilia B is a smaller point mutation. So I just wanted to add that in case Dr. Sobring asked. So this also shows the concept of skewed X inactivation. So if you have, typically when you have X inactivation, it should be about 50-50. So if for whatever reason you have more, say 70% of the mutant allele, you may, the female with the X, that's an X carrier, may actually show symptoms, but this is this skewed inactivation. All right, so for ventilation.
Brady, we have a request to take like a 5-minute break before we do
I would love
ventilation.
a 5-minute break. Thank you so much. All right, we'll take a 5-minute break. Come back in 5 minutes.
We appreciate it, man.
Yeah, no worries, dude. I know this material is dense, but we really wanted to try to cover everything, all the high yield stuff that they could ask. So if y'all understand conceptually what we're talking about here, like you should be able to do well on the exam. So, all right, let's see. So for ventilation, this actually was on our BSc, which was like one of those, what? I was like, what? How dare they ask us that? Right, so make sure you know this equation, the PiO2. They could have forward equation. Just make sure you know it. Minute ventilation, simply put, is how much air you're breathing
times the frequency over a minute, right? So that's an easy equation to remember. And then dead space is, typically we talk about this in regards to anatomical dead space, because if you're healthy, the only dead space you should have is anatomical. But understand, if you have some sort of pneumonia or fibrosis or something like that, you could get this physiologic dead space. So ideally, the conducting zone is going to be your dead space, right? You're not, no oxygen is being exchanged. Now, and so in a healthy individual, that's the only part that's going to be the dead space. The actual alveoli is going to become completely there for oxygen exchange. So yeah, this is equation, but this makes sense. Like when I do the equations, if I can't, some of them you just have to memorize. It's harder to hear me. I'm sorry, guys. I had to switch them over. I'll try to talk louder. My other ones were dying. So yeah, so if you look at this equation, when I do the equations, if I could try to wrap my head around it, it makes it easier for me to remember the equation. But alveolar ventilation is going to be everything that's not dead space ventilation, right? So you take your tidal volume times the frequency, and you subtract the dead space, and that's how much is going to get into your alveoli. So yeah, so you can remember this equation here. Right, so when we measure dead space, they talk about these two different methods. I don't know that it's terribly important. Like, we're gonna just touch on it a little bit. So with Fowler's method, they use nitrogen to measure it, but it's just you're trying to measure how much is anatomical dead space versus how much is actually the part where you get gas exchange. So this isn't the one that's super important. The one that you probably get asked about is the Bohr method, right? So if you think about this dead space over tidal volume, that's going to give you a decimal point, but that's going to be your percentage. So you're saying the dead space is equal to whatever, and this is going to correlate to the alveolar ventilation. So the key thing here is you're assuming that alveolar CO2 and the arterial, the CO2 in the blood are the same. So by doing that, you're able to exchange this. And so you're basically saying dead space is equal to the total volume minus whatever the alveolar ventilation is. So just keep that in mind. So this way you don't have to do Fowler's method. You don't have to suck down a bunch of nitrogen or something. You could just get blood work. Okay, so this is kind of classically how it goes. If you have blood coming in from the left and going to the right, you are going to get gas exchange right when you get to the alveoli. So you want this thin membrane here. You don't want fluid in the alveoli. You don't want some sort of embolus here that's going to stop blood flow, right? So once you get here, you're going to get exchange. The carbon dioxide is going to go across and you're going to get exchange for oxygen. So that makes sense. Well, once you understand the normal, then it's much easier to understand the clinical problems. I just put these in here because I think these are fair game. I'm not sure if we exactly mentioned it, but for our test, a lot of the math was straightforward. I remember harping on a lot of the equations and they ended up not even being on there. So I think the school does understand you don't have scratch paper, so that's understandable, and they do their best to work with you. But I do think these are fair game questions, and definitely you want to know the AA Brady. So you're just asking yourself, what is the difference between ventilated oxygen versus the oxygen in the blood? So ideally, it should be about the same, right? I think the normal values is about 5 to 15. Anything greater than that, then there's a problem. And you can see that here. One of the key things you want to remember is that if you get hypoxemia and you get a different gradient between what's ventilated and the air that is in the blood, you're thinking that there's some sort of pulmonary problem. But the one thing that stands out here is if you're hypoventilating, you're going to get a normal AA gradient. So that's a good test question you can ask. And that makes sense because if you're just decreasing your ventilation, then you're decreasing the oxygen in. So you're also going to decrease the oxygen that's going to get to the blood, right? So you would expect a normal AA gradient. If you have some sort of pulmonary problem, then like some sort of fibrosis or pneumonia or something, then maybe the air ventilated isn't actually getting across the membrane, right? And it's not going to get into the blood. So keep those separate. And when they talk about hyperventilation, you get a normal AA gradient. Now, we talked about this a little bit before, but the way it works out is that towards the lower aspect of the lung, because of perfusion of blood is gravity dependent, you're going to get more blood at the bottom. And remember, I told you that the lung has more of this like slinky effect. It kind of, it's held from the top, so it's going to expand more at the bottom. And that allows the ventilation to be greater in the bottom as well, which is perfect because the area you want to ventilate is the area you want perfused, right? The greatest point of perfusion is where you want the greatest area of ventilation. And so that works out well for gas exchange. Just a little summary here. Remember that the ratio is highest at the apex. What does that mean? So if VA is the numerator and Q is the denominator for perfusion, you're not going to get a lot of perfusion at the apex. So this number is going to be greater. So it's highest at the apex. You want it to be towards 1, right? You want it to be equal. So we talk about vasoconstriction. So just remember, are we talking about the numerator when we talk about ventilation, or are we talking about perfusion? Well, if you get vasoconstriction, you're decreasing the denominator, right? So you may get proper ventilation, but you're decreasing the amount of perfusion. Whereas bronchoconstriction, you are decreasing the amount of ventilation, but you may have a normal perfusion. So keep those in mind when you're doing these equations. And here's a good example, right? So in this scenario here, we have some sort of, say, mucus blockage or whatever. The point is that you get decreased ventilation here. So you're decreasing your V. Now the perfusion's okay. So here you're going to get a low VQ ratio, right? Because the numerator's decreased and the denominator's the same. Here, this will be normal, right? You should get proper exchange. But here you're getting some sort of pulmonary embolism, right? So you're blocking the blood flow. So here the ventilation is okay, the numerator is okay, but the denominator is going to be decreased. So you're going to get a high VQ ratio. So the easiest way to do this is just to remember numerator over denominator. And if you do that, you can differentiate whether it's some sort of problem with ventilation or some sort of problem with perfusion. All right, and then this is just another slide to go into whether you want to measure the AA gradient. Remember, normal is about 5 to 15, and with age, you get a lot of problems with gas exchange, whether it be fibrosis or whatnot. So this value is going to increase with age. And I just wanted to point this out one more time. Remember that hypoventilation isn't going to change your AA gradient. If you're bringing in decreased air, you're going to have decreased oxygen in the vessels as well. So both numbers will be decreased, so it's not going to change it. Excuse me. And this is just a graph if you're one of those people that likes to break it down this way. AA gradient's normal for hypoventilation. If not, you have to ask yourself what's going on. Do we have a problem with blood? Or do we have, do we have a problem with air? Are we shunting air away from some other problem? Or do we have some sort of diffusion problem?
Sorry, Brady, can you explain the difference between diffusion and the physiological shunt that comes with it? Or the VQ mismatch, sorry, because sometimes if ventilation is too high, or is it perfusion is too high, you technically get a shunt. So I just don't know when to differentiate both.
The shunt is referring to a blood shunt.
Wouldn't you get that with a decreased perfusion? So the VQ mismatch would also happen?
I'm sorry, wait, diffusion.
Or yeah, perfusion. I keep confusing both, but that's what I meant.
Blood air the shunt is, I'm sorry, the shunt is for, the shunt's for blood. No, the shunt must be, I'm trying to differentiate.
The shunt's in right atrial, left atrial shunt, usually, isn't it?
Well, we're talking about shunting of the pulmonary system right now. So if, for example,
Yeah, go ahead.
So if, for example, we have a PE, a pulmonary embolism, that is blocking the blood flow through a certain part of the lung. That part of the lung is not, it's getting ventilated, but it's not getting perfused. That's a shunt because you're not getting, that's a VQ mismatch at that area because you're not getting, you're getting ventilation, but you're not getting blood flow over there. So that's a shunt.
Right. And I get that. I just don't know when to differentiate between saying, like, when they give you, oh, this person, we put O2 therapy for them and it didn't work, or it did work.
Yeah.
And I don't know when to say, oh, it's a physiological shunt versus a VQ mismatch, because technically, if there's no perfusion, you would also get a VQ mismatch. Like if there's a shunt, a physiological shunt where there's no blood going, you still get a VQ mismatch.
Okay, so the idea here is that, so this is a blood shunt. I was right, because you can't correct a blood shunt or some sort of embolus with O2 therapy, because there's no blood flow, right? So if they're talking about getting O2 therapy and nothing works, if you don't have blood flow, you can't shunt it. Now, when you have a diffusion problem, a lot of times if you increase the oxygenation, it's going to open up the vasculature, or I'm sorry, it's going to open up the pulmonary circuit. So you can actually increase some of the area that's not being ventilated as well. And then by doing that, you can get oxygenation. But understand that these go together, right? If you get a decrease in diffusion of air through the system, you're gonna want to vasoconstrict the vessels, right? Because you're telling the body there's no point in shunting blood that way if there's no ventilation. So the idea is a lot of times different parts of the lungs, like for example, if you're ventilating the lower part of the lungs more, a lot of the vessels are going to be vasodilated because you're going to want to get more oxygen to the area that has more blood for exchange, more oxygen for exchange. So the question here is, what's the primary problem? And to define that, you have to say, well, does oxygen work? Obviously, with diffusion, you can give oxygen and it'll kind of open up the airways. But if you don't have blood flow, no amount of oxygen therapy is going to change it because you can't get the exchange across. But yes, this is asking what the primary problem is, and the counterintuitive or the counter product would be to try to compensate with the other side. And but in normal circumstances, even just physiologically, if you have an area of your body or of your lungs that's going to have better diffusion, you're going to try to vasodilate those vessels. But yeah, just ask yourself if O2 therapy doesn't work, then it has to be a blood problem.
Thank you.
Okay, and then quickly we could just look at what happens. The main point that happens at high altitude is you're going to get increased 2,3 BPG. So if you ever seen people that go climb Mount Everest, they have to stay at the base camp for like a week or 2 weeks or maybe even 3 weeks just to kind of equilibrate, and they're going to increase their 2,3 BPG. Well, what's that going to do? That's going to tell the red blood cells to offload more oxygen to the tissues. Now, what's counterintuitive, you actually have the same amount of oxygen at altitude as you do at sea level. It's just a decreased pressure. So even though you have the right amount of oxygen up there, you don't have the pressure to get it across the alveoli. I never knew that until recently. But yeah, so the idea is that with the decreased pressure, the hypoxia, you need to have mechanisms. So obviously 2,3 BPG is going to be a main one to say, of the oxygen we're getting under this low pressure circumstance, give it to the tissues, right? Offload it. And we'll get into erythropoietin when we do renal later, and because that's a long-term mechanism of increasing blood. But as they climb Mount Everest, they have to stop at certain base stations or certain stations and stay overnight as they get higher up. Okay, and then some of the effects, you can get this mountain sickness. So cardiac output's going to go up, and you get sympathetic stimulation. So you're going to get an increase in hydrostatic pressures. So what can happen is under these circumstances of high altitude, you can get pulmonary edema. If that's indicative that cerebral edema is also a possibility. This is more of a longer effect or a prolonged effect. So the idea is if somebody's up at altitude and they get pulmonary problems, pulmonary edema, you want to get them down the mountain or down to sea level before they get cerebral effects. All right, glycolysis, which hopefully you remember from undergrad, even though every time I learn it, I have to relearn it. So I don't know. Go ahead and try to answer this question real quick.
Don't try to become an expert on glycolysis in term 1. You'll do that in term 2.
Yeah, for sure. I put some of the slides that I remember because I was worried about that in term 1 too. I was like, do we really need to go into this like crazy? But the questions were really straightforward. You're going to want to focus on the rate limiting enzymes and the places where you can get problems, pathologic problems. But we'll get into that in a second. You want to go through this one, Lindsay?
Yeah. So most people are picking D, which is correct. So when we're talking about substrate level phosphorylation, you can put in the chat, what are we talking about when we say that term?
ATP in glycolysis?
You're making ATP. So you're going ADP to ATP. That's what they call phosphorylation. And so you have to look at these enzymes. And so basically what I'm asking you is which one of these enzymes is involved in a step that does ATP? Now, a quick trick, kinases are associated with phosphorylation. So if you just look at the names, even if you didn't know where any of these are, a kinase is associated with phosphorylation. So that should narrow it down for you right there. G3P dehydrogenases are associated with NADH, and so that is not associated with ATP. PFK1, this uses ATP, so it's energy, you're putting energy into the system, you're not getting energy out. Lactate dehydrogenase isn't in glycolysis, it's kind of at the end step. Phosphoglycerate mutase, this just shifts around a molecule, and then hexokinase is that initial step in glycolysis. So the big one here, phosphoglycerate kinase, another would be pyruvate kinase. That would be one as well.
I added this from first aid. It kind of just outlines the difference between hexokinase and glucokinase. So if you remember the KM, they're inversely proportional to affinity. So the lower KM means decreased affinity. Why is the KM, why does the tissues have increased affinity? Because the tissues they want to grab on to the glucose when it comes in. Glucokinase is more in the liver. It has a decreased affinity because there's tons of glucose. It just wants to mop it all up, right? So these are kind of, I like it next to each other because you can kind of just bounce the differences off to see there. This, I put a star on this. This is kind of what Lindsay was talking about. I have another slide outlining it. Remember, kinase is adiphosphate, and these are two of the three rate limiting enzymes, 1, 2, and then PK pyruvate kinase is one as well. I'll put this here. This will be super important for the test. Like we said, you don't have to dive too deep into it, but understanding these, the rate limiting enzymes, that means they don't go bidirectional, right? You need these to go make glycolysis. For gluconeogenesis, you use a whole different pathway, but y'all learn that in detail next term. Like Lindsay said, kinases are going to add the phosphate. We talked about this as well with this 2,3-BPG. If you remember this little pathway, remember if you have hexokinase, you're not going to get to need 2,3-BPG. Without 2,3-BPG, we have a left shift. Pyruvate kinase should get back up. Let's increase 2,3-BPG because it's backed up from this point. Increase 2,3-BPG means decreased affinity, means we're offloading, right? 2,3-BPG, remember when you hear that, remember tissues. What do you want in the tissues? You want to offload. And then I kind of outline that. Okay, and then yeah, this is a mutase. The mutase actually makes the 2,3-BPG. see. This is just kind of what I found for you. Again, the same thing. This is a good explanation how they can ask a question about glycolysis and involve pulmonary as well. So just make sure you keep these in mind. What 2,3-BPG does. I'm not sure if I meant. Yeah, I did mention the fetal hemoglobin. Remember, that's a left shift, because so fetal hemoglobin will present very similarly to hexokinase, because you're getting a decreased affinity for 2,3-BPG, right? So you're getting a left shift. Hexokinase is also going to cause a left shift. Pyruvate kinase is going to cause a right shift. And this is kind of the process of the cell lysis, and this is important as well. I'll put a star on it. So with both hexokinase and pyruvate kinase, the problem here is that if you can't go through glycolysis, you can't make ATP. If you can't make ATP, you can't operate the sodium potassium ATPase. And if you can't operate the sodium potassium ATPase, you're going to get this ionic imbalance. And if you do that, have an imbalance, remember that water goes with sodium. So if you get this imbalance and you can't equilibrate, or you can't operate the NAK ATPase, you're going to end up with cell lysis. So you can get blood in your urine, bilirubin. That's going to cause that. So just remember that that's the mechanism. Decreased ATP will cause decreased sodium potassium ATPase. Now remember, there is a different pathway. You can also go to oxaloacetate, but you're not going to worry about gluconeogenesis right now. Just remember, under anaerobic glycolysis, with no mitochondria, such as with the red blood cells, you're going to go towards lactate. Anaerobic glycolysis using lactate dehydrogenase, that's anaerobic glycolysis. And remember that the Cori cycle is going to be what you take when you make this lactate from red blood cells or the skeletal muscle. You go back to the blood, and you can go back to the liver to make the lactate go back to glucose. So that's the Cori cycle. And then lactic acidosis. We're going to talk about this in renal because Lindsey and I were talking about this earlier. We had probably 30 questions on the acid-base problem. So by all means, this afternoon, we will make sure you know how to do those backwards and forwards, because we literally, I swear half the test was those questions.
And so it does get easier.
It does, but if you know how to do those, you will just crush the test, because that was a whole bunch of questions. So we're going to break it down question by question, and I'm going to show you how I do it. And if you do it that way, you should be good to go. Okay, so this is just similarly, remember these irreversible reactions and these rate limiting steps that we talked about, and the kinases make ATP. This is just the difference. If you want to break this down, remember glycolysis under aerobic conditions, you make 8 ATP, whereas only 2 with anaerobic. Okay, yeah, do this question. Okay, so y'all are doing acid-base tomorrow. Oh shoot. Well, we'll go through it today anyway, just to show y'all how to do it.
Yeah, because it does get confusing, so.
Yeah, we'll do it today, and I have a method of doing it that's pretty fail-safe. So we'll break it down this afternoon for you guys.
Yeah, you'll get an intro.
Yeah, for sure. Okay, here, remember that you use those GLUT transporters. Remember that the GLUT transporters use facilitated diffusion. That's the mechanism that they use. You want to make sure you memorize these. 2's in the liver, 1 and 3 neurons in brain, 1 is red blood cells, 4 is insulin dependent, and 5 is fructose. So remember, these GLUTs are facilitated diffusion. All right, almost done. Did y'all do any acid bases yet? Y'all did the beginning, right?
Yeah, we had an answer to it on Friday.
Y'all just haven't done problems yet.
Yeah, and then we have 2 lectures on acid base tomorrow, and then we have our last lecture on Tuesday, but the doctor said that it's going to be more of like a flipped classroom with the acid base.
Oh, I remember that. I remember that class.
Well, ideally by the end of today, you can do them and then you'll get all of the flipped classroom questions right. It's your goal in life. All right, what are we talking about? We talked about this. Remember the affinities inversely proportional to the Km. So glucokinase is going to have a higher Km than hexokinase. Just differentiate these from that graph I put from first aid. This is another way of understanding it. Let's try this one. Patient has met hemoglobin. Remember, these are those blue patients, right? And what is the problem here? They're blue because they have ferric iron. Ferric iron is going to be the +3 state. Oxygen doesn't bind to that. That's why they're blue. They're deoxygenated. Blue means deoxygenated. So yeah, D is going to be this ferric state.
I have a question. Are these people like super sick, or like do they have any other compensatory mechanism? Because in the picture you see just blue people, but I'm like, if they cannot.
It almost looks photoshopped, huh?
Yes.
That's a good question. Maybe like they have some mechanism to use like fetal hemoglobin or something like that, or something other than this, but I don't know. I know that they are medications for it now, but yeah, that's a good question.
It kind of looks like lethal, almost. Like if you look at the whole description, I'm like, how am I gonna have someone with this disease alive?
Yeah, I don't know. I honestly don't know. All right, let's see. PK deficiency. So what do we remember about that? Remember, if you have pyruvate kinase, that means you're going to get a backlog. You can't finish glycolysis. You can't finish making those ATPs, and you're going to have an increased 2,3-DPG, which is going to cause a right shift. So let's see. Right. So if we have a right shift from too much 2,3-DPG to low affinity, right? So that makes sense. And remember, they're going to get cell lysis, so they're going to get that hemolytic anemia. Then we have this again. Let's see. Okay, this is kind of like a memorization thing. If we talk about fluoride. And this is that step, that arsenate step. Or what is the enzyme, that fluoride? It's not arsenate, that's another one.
Enolase?
Is it enolase? That's it. There we go. Yeah, so that's that enzyme here. So y'all know what y'all are doing. All right, good. Yeah, here it is. I said arsenate. That's a different step, right? So enolase and fluoride, easy points if you just remember where these drugs. This is arsenic too, so it's the same thing. And fluoride, that's how they do the blood tubes. So they put fluoride in these tubes. That way, when you get blood that doesn't continue glycolysis, and you get a good measurement of your glucose level. All right, let's see. Does not sense, this is more of a renal question, but we can do it. Does not sense fullness of the bladder. So the bladder is an organ. Yeah, right. Organ and then sensory or motor. We're talking sensory. So visceral is organ, afferent. Typically, you think of visceral afferents as more of a pain thing, but these stretch fibers are also visceral afferents. Very good. You can see that here. History of asthma. Respirations are 14. What's the normal respiration rate? (12 to 16 is normal respiration rate. Yeah, 12 to 16. Yeah, I'd say 12 to 16. Yeah. So 14 is normal. So we would classify him as eupnea. Remember, apnea, A means no breathing. Dyspnea means difficulty breathing. Tachypnea means increased respiratory rate, and eupnea is normal breathing. So just the fact that it's 14 tells you that it's normal. You can see that here. Oh, let's do math real quick. End it with math. This is fair game for this question, to do this. So for the sake of, yeah, I'll give y'all a second. We'll try this one. All right, so basically we're asking straightforward this percentage, this dead space percentage. Do you know what the dead space over the tidal volume ratio? So I think I have, yeah, the equation here. So it's PaCO2 minus PeCO2 over P little a CO2. And so you would get 0.4. But this is just one of those ones, if you know the equation, you can just plug in the numbers. And this is all posted for you guys.
Is it okay to use the other formula, the one where it's 1 minus Paco over Paco? Is that okay? Or do you have to know it this way?
Oh, I think this one is just this way. I'm not 100% sure, but because we're specifically asking the dead space over the tidal volume.
I think it's the same thing because that's what.
Yeah.
Yeah.
Okay. Yeah. If that
Yeah, I
works,
got the
then
same
that's
thing.
fine. Okay, cool. Yeah, that works. Did somebody say tacos? Somebody said taco. Taco. I want a taco. All right. On standing, so gravity is going to be dependent. So when you stand up, blood flow distribution, right? You get orthostatic hypotension, you get lightheaded when you stand up. You get blood flow. And that's that VQ mismatch we talked about, this perfusion. Right, so you remember that you want oxygen to bind in the relaxed form. So remember, when it's relaxed, it's opened up so the oxygen could bind. The key here is that carbon dioxide, the amount of taut hemoglobin, or carbon dioxide is going to close it up. It's very selfish, right? So when carbon dioxide binds, then oxygen's not combined. So that's the key thing here. Just make sure you remember the difference between relaxed is open, so oxygen can bind, taut is kind of closed off, right? So once the carbon dioxide binds in the taut form, get it back to the lungs, and you can get rid of it via bicarbonate. And then remember our curve here, right? More shifts. And that's it. Everything will be posted. We will do the second one at 6 p.m. AST. We'll post the slides beforehand. Everybody go take a 5-minute break.
Brady, quick question. I'm sorry.
Yeah,
Can you go back
no
to the
worries.
last question and explain it again? The whole relaxing taut form.
Yes.
Yeah, this one.
Thank you.
Yeah,
Thanks, Brady. Thanks,
no
Linz.
problem.
Oh, I'm here.
Did you have a question regarding it?
Oh yeah, can you explain it, please? I didn't catch it.
So the idea is that when you pick up oxygen in the lungs, the hemoglobin is in the relaxed form. It's relaxed, meaning I like to think of it as the hemoglobin's open, right? Because it's relaxed. So the oxygen has places to bind. In the tissues, after you get rid of the oxygen, that's where the carbon dioxide is going to bind. And it's going to form this taut form. Taut meaning it's tight, it's closed off. So when carbon dioxide is bound and the hemoglobin is taut, then oxygen is not going to be able to bind. But that's fine, because the whole point, once you get from the tissues in this carbon dioxide, is you want to get the carbon dioxide back to the lungs so you can get rid of it. Once you get rid of it, the hemoglobin opens back up to the relaxed form and oxygen can bind again. And remember,
Okay, got it. Thank you.
Remember, hemoglobin has that sigmoidal curve, right? Because it's the
Right.
cooperative binding. Yeah.
Thank you so much.
Yeah,
Just
no
to
worry.
follow up on her question, so is it fair to think of the thought form as a right shift? Would
Yeah,
that-
yeah, actually, yeah, right. So, if it was already right, like a right shift will cause the taut form, opposed to taut causing the right shift.
Right, because the oxygen leaves and then it shifts to a tense, right? Is that the right logic?
Yeah, once the carbon dioxide binds. Yeah, so it gets rid of the oxygen and then carbon dioxide binds, and that promotes the taut form. Yeah, because it'd be kind of weird if you had carbon dioxide and oxygen binding at the same time. Like you want it to go lungs as oxygen to tissues, and then tissues carbon dioxide back to lungs. You know, so it works out well.
But thank you.
Yep, no worries.
So much.
So everything will be posted on the page. I think if y'all want to snap, this is for the Google Drive, but there's a link there as well. If y'all need it.
Are these slides a combination of the slides that you already posted this week?
Most of them are, but I added a lot of stuff actually, and Lindsey's questions as well. So there's probably, for this one, there's at least 6 or 7 more lectures that were added at the end.
Okay, and did we go over the DLAs, or that's not important?
No, we this is pretty much everything. I felt.
Yeah, this was all encompassing.
Yeah.
Oh, okay, thank you.
Yep.
Some of the DLA stuff, just remember it intertwines with the lecture stuff. So.
And I'll try to get the video posted as soon as possible for you guys.